Live now.
Good evening. Welcome to Retinoblastoma 2022, our international symposium on the occasion of World Retinoblastoma Awareness Week. This program is being organized by the All India Ophthalmological Society, which is the world's second largest association of professional ophthalmologists, secretary of which is dynamic Dr. Namrata Sharma. I request her to give a brief introduction.
So thank you, Santosh, for doing this. And this is a Retinoblastoma 2022 International Symposium. And Dr. Santosh Honawar, who's the editor of Indian Journal of Ophthalmology and director of the Ocular Oncology and National Retinoblastoma Foundation Center for Sight, Hyderabad, who has a keen interest in retinoblastoma and I think is totally committed to retinoblastoma, does this every year on the platform of All India Ophthalmological Society. And I'm very delighted that we have speakers from all over the globe, right from UK, Canada, US, Switzerland, Argentina, Singapore, and almost encompassing the entire globe. The presentations will be done by them and they'll be discussed by our Indian counterparts. So thank you, Dr. Santosh, for doing this yet again. And there are a lot of people watching on the Facebook, on the YouTube. And like always, I'm sure it is going to be really very well attended. And I'm sure people also would be looking forward to the exciting quiz that is going to follow after this, which will immediately follow the question answers and the panel discussion as well. So over to you, Dr. Santosh, for taking this forward.
Thank you so much, Namrata. Thank you for your encouragement and the support that All India Ophthalmological Society always gives for such events. I'll very briefly introduce the faculty. We have a galaxy of international and national faculty. Going by the order of appearance, it is Ashwin Reddy from Moorfields Eye Hospital, London. Ashwin is a close friend. He has an Indian origin but works in London currently. Ashwin Malipatna, again of Indian origin, was earlier. Currently is at the Retinoblastoma Service at the Hospital for Sick Children, Toronto, Canada. Don Gambos is from MD Anderson Cancer Center, Houston, Texas. He is the current president of the International Society of Ocular Oncology. Everyone knows Dr. Carol Shields, our mentor. She is from Wills Eye Hospital, directs the oncology service at Wills Eye Hospital, Philadelphia, US. Francis Munier is from Jules Koenen Eye Hospital, Lausanne, Switzerland. Jess Berry is the secretary of International Society of Ocular Oncology, and she works at Children's Hospital of Los Angeles, California, US. Ralph Eagle, again, a mentor for many of us, is an ophthalmologist, pathologist from the Wills Eye Hospital, Philadelphia. Dr. Shantada is an oncologist, and he is from Spain. Dr. Helen Dimaras is from Hospital for Sick Children, Toronto, Canada, and her special interest is in genetics of retinoblastoma. And closer to home, Gangadhar Sundar is from Singapore National University. He's an oculoplasty surgeon with special interest in retinoblastoma. Our national faculty include Dr. Bhavna Chawla, who is professor at the Dr. Rajendra Prasad Center for Ophthalmic Sciences, which is part of the APEX All India Institute of Medical Sciences, New Delhi, India. Dr. Aksharov is a faculty at Narayan Netralaya, Bangalore. Sumit Lahane is a young assistant professor at JJ Hospital, Mumbai. Dr. Mahesh Shanmugam is one of the most experienced ocular oncologists in the country. He is from Shankara Eye Hospital, Bangalore. Fairuz PM is from Horus Specialty Eye Care, Bangalore. Dr. Swati Kaliki represents LV Prasad Eye Institute, Hyderabad. Kaustubh Mule is a pathologist attached to Center for Sight, Hyderabad. Dr. Vijayanand Reddy is an oncologist who guides both Center for Sight and LV Prasad Eye Institute for ocular oncology services. And he's affiliated to Apollo Cancer Hospital, Hyderabad. He's the director. Usha Kim has a special interest in genetics of retinoblastoma, and she heads the oculoplasty and oncology service at the Aravind Eye Hospital, Madurai. And Seema Das leads ocular oncology at Shroff Charitable Eye Hospital, New Delhi. And I'm from Center for Sight Eye Hospital, Hyderabad. So let's begin with the panel discussion first. everyone who has joined so far will be part of the panel discussion. So I will ask a particular person, but you can definitely, chip in and answer any question that you feel is appropriate. So we have a bunch of slides here, but I don't think we'll be able to complete all of it. Maybe even if we get to 50% of it, that will be fine, because it covers the entire spectrum of retinoblastoma as we see. Let's take the first question. This is a young child with bilateral retinoblastoma. Left eye has group E retinoblastoma with neovascular glaucoma, and right eye has a small tumor in the periphery. So how do you like to treat this small tumor? Of course, left eye will be enucleated. Now we are left with a small tumor in the right eye. So what would be your preferred focal treatment of choice? Remember, this program is being watched mainly by ophthalmologists, retina specialists, general ophthalmologists, everyone. So level of discussion can be kept to intermediate level. So Ashwin, do you want to take it? How do you treat the right eye? What is your preferred?
A couple of Ashwins here, Santosh.
That's right.
You're London Ashwin or Toronto Ashwin?
Either.
Okay, I'll kick off then, and then Toronto one could come in as well. So yeah, we give cryotherapy, 3 freeze thaw. That would be pretty standard. See again after 3 weeks and repeat. Difficult to see the size. It's probably about a good millimeter in diameter or so. So yeah, that would be our strategy for this.
Mahesh, would you treat it differently?
Yeah, I would probably use TTT with the laser indirect ophthalmoscope. It's much easier because it's not too peripheral, so I'd probably use TTT with much less scarring as compared to cryo, and the orbital edema and the conjunctival edema is much less with the TTT.
Clearly, choices are cryotherapy versus TTT. Would anybody do laser photocoagulation at all currently, or Dan is?
I think laser photocoagulation is not out of the question in this kind of a tumor as well. I think treating both around and on the tumor, if it's this peripheral, is perhaps not a bad idea.
If you don't have access to TGT and don't want the inflammation that is produced by cryotherapy, perhaps for a mid-peripheral, peripheral tumor, you can do laser photocoagulation. Is that your suggestion?
Yes. I personally don't use TTT like it was designed. I think we all use the 810 long pulse, but a smaller spot. But a 532 nanometer in this situation will do as good, I think.
Santosh, just two points.
And you can see a crisp scar. Of course, there is absolutely no problem using cryotherapy, and for a peripheral tumor, laser photocoagulation can also be probably considered. So,
Santosh, can you hear me?
We can hear you, Dan. I think Santosh is frozen, maybe.
Yeah.
Oh, Santosh is frozen. Yeah.
Dr. Gombas, please go ahead. Yeah.
You know, it's interesting. I completely agree with what everyone has been saying, that I personally would enucleate the EI and do cryo for the small tumor. So let's be clear, but I think it's an interesting discussion that we want to start having. There are centers that would advocate intra-arterial chemotherapy for that group EI. Again, I would not, but there are people who are advocating and attempting to salvage a globe that advanced. As it relates to photocoagulation, I think there's no doubt that in the past it can be done, but I've certainly seen in the past few years people attempting laser photocoagulation and inducing vitreous seeds. And so it can make a very salvageable, if you like, easy case right now, potentially more problematic. So it needs to be, we talk about laser all the time, but we rarely talk about the details of how we do it, the wavelengths we use, the energy settings that we do. Do we go around? Do we go above? How many times we repeat? All these sort of things. It's sort of an interesting thing that we always talk about focal therapies as if they're administered in all centers in a uniform way. Far from it. there's probably enormous disparity in how we all do focal therapy.
If I could just add on top of that, yeah, we did a Cochrane review a few years ago about laser or any laser technique, TTT, and you're quite right, the evidence is not out there. So what we'll have different centers doing different things and getting good results. In our hands, cryotherapy seems to work better than laser. And so with small tumors, especially with very small babies, we prefer to go to the cryo earlier. That's in our experience with the laser. We used to use TTT, and we moved more to focal therapy. The Toronto group have published some quite nice papers recently on that, their use of focal therapy, 1 second focal therapy. So that's where we're heading to based on that. Thanks.
Thank you very much, Dr. Ashwin. I hope Dr. Santosh is back.
Yeah, I'm back.
All right, yeah.
There are issues, internet issues. Anyway, so this was a patient who also had a small tumor. This was treated with TTT, and you find a small scar here. So when you do TTT, how tight is the TTT? Do you do only on top of the lesion, Fairuz, or do you want to do slightly around the lesion?
Yeah, so, well, yeah, in my practice, I use TTT, and it's a large spot that I use specifically. So I would go a little bit around the margin as well, Dr. Santosh, on the tumor, and a little bit, the circle will be slightly over the margin, away from the margin as well, so that it's completely covered, because we do see margin recurrences in our practice, irrespective of the size of the tumor. So, well, I do take care of that as well.
So this was a tight TTT. This was done right on top of the tumor, and this was also a small lesion, which was also lasered. I mean, TTT was done right on top of the tumor, but you see an edge recurrence right there.
Yeah.
Right. So possibly, although we were taught that TTT should be tight, if you go around the lesion just a little bit with overlap onto the normal retina, maybe this possibility of edge recurrence will be minimal. What do you feel, Bhavna? Do you feel the same? Raksha, what do you feel?
Yeah, I completely agree with Dr. Fairuz. To prevent edge recurrences, each spot of TTT that we give, a large spot, partly the spot covers the margin and partly beyond the margin. So it's around the entire tumor, encircling not only the tumor, but also over the edge and around.
Yeah.
Ashwin wants to say something. Ashwin, you have raised your hand.
Yeah, I think these posterior tumors are very, very amicable to OCT. Being very precise with an OCT will allow you to laser exactly the amount that you need to and not more. You do see areas over the edge of the tumor that are potentially active, and monitoring that over time with OCT is something that we could do. I know that Bangalore has a bioptogen. We have a bioptogen here, but other OCTs like the Spectralis work well enough. And we use that quite often for small tumors like this to monitor treatment and monitor the immediate response of lasers as well.
So you do it in every patient,
If it's a posterior tumor like this, yes, in every patient we'd be doing it. We'd also be following up the scar with OCTs, so then we can look for recurrences much quicker than they can be seen. And that was my answer. Sorry.
No, I was just asking the rest of the panelists if any of them would use OCT routinely.
We have OCT. I've followed the work in Toronto closely. I think they probably have been the biggest advocates of using OCT and monitoring things. I think my value of the OCT, I have the bioptogen as well, is when there's some question, you'd like to have some diagnostic certainty about not just retinoblastoma, but other simulating lesions. You want to see exactly where it is. I think another key point that we're not getting to is how many cycles of thermal therapy you administer. We go back to Lynn Murphy, who really was the originator of chemothermal therapy, and that we don't use that term as much as we used to, but let's remember Lynn's work here. He would advocate that every tumor needed to be treated at least 3 times with laser. And I have kept that in my practice, and I'm not saying it's perfect, but I do think sometimes people say, oh, after one treatment, it looks great, it looks dead. We need to, reinforce to people who manage this disease the importance of multiple administrations to really make sure that it's fully consolidated.
Dr. Santosh, if I can add something here.
Sure.
Yeah, it's just that, if everyone is watching, so when it's a foveal tumor, probably, there is some amount of conservative way of applying the TTT.
Sure.
Yeah.
You would want to avoid TTT if it's a foveal or a macular tumor and try to be more conservative than that. And only if it's, following optimal chemotherapy, if the tumor has not regressed, then possibly very gentle TTT.
Yes.
Yeah, so this was I suppose, a very large scar. This was treated elsewhere. You can see, of course, these are artifacts, and this is the tumor that has been treated. And you can see a very large scar disproportionate to the size of the tumor. So what are your TTT parameters? Possibly this was over-treated. This looks like it's been over-treated. So what are your TTT parameters? What is the kind of, for a tumor that's about 3 millimeter thick, what would be your settings? Say Caucasian eyes, pigmented eyes such as ours?
I think you hit it right out of the ballpark where you said, is it a Caucasian eye or is it a pigmented eye? Because that significantly impacts the amount of how high you have to go in your milliwattage. So I was always taught to start low and slowly increment, and I increment in about 50 milliwatt increments until I see some sort of response. But there's enormous variation, especially in very young, hypopigmented Caucasian patients, like I recall seeing in the UK when I trained there, versus the deeper pigmented Hispanic patients that I manage in Houston, where you can start to see uptake at a much lower setting.
Mahesh, any thoughts on this?
Yeah, I would probably start off with around 200 milliwatts, and I usually use probably about a minute's duration. And if it's a very dense white burn, like a photocoagulation burn, is when you would get a dense scar like this. A slight color change towards the second half of the minute is what I would look for, and that usually is adequate enough to regress it. Another distinction is if in case the other eye needs chemotherapy, then again, like the power used can be much lower than the higher person. If the patient is already undergoing a chemotherapy, and then you're treating the eye with a smaller tumor like this, then the power use can also be much lesser.
Anyone else who wants to comment on the number of spots that you can use maximally? Is there any limit at all, or you can continue to use as many spots that are required as is for the tumor? Is there any limit at all?
So the scar there, I agree with you that it looks a little bit over-treated, but I guess my question is there a harm in over-treating? I don't mind maybe treating a little bit over rather than under-treating in some way.
Well, the harm is that it may produce atrophic retinal holes. It works like photocoagulation. Then you lost the advantage of doing a gentle, so-called gentle TTT.
Sure, I fully appreciate that we want to do it as gentle as possible, and I think that's how I approach it as well. But when we do treat a scar, we're treating only the center of the scar and not the periphery, which is quite well scarred anyway. So treating the center and treating it a little harder sometimes in suspected recurrences is something that we employ, but mostly as gentle as possible.
About the number of spots, for example, if you're using, say, 9,000 milliseconds spots, say, using 300 to 500 milliwatts, what is the limit to the number of spots? Do you have any limit at all? Because we were taught, and I still practice, the fact that TTT should not exceed more than 5 minutes in all at a session, because then the chance of cataract, at least in pigmented eyes, would be much higher. Acute onset cataract because of lens hydration. Lens absorbs some amount of energy. So is that the standard principle that you operate on, or is there any variation of this thought process?
We go 400 millisecond spots with green laser. and we go on the tumor as close to the margin as possible and a little bit around the margin if it's that peripheral. So I think we would do, I would do about 100 spots right there is what I think, maybe less, 50 to 100 is what I would say for a tumor of that size maybe. And this is a small spot, not a large spot TTT, of course.
Has anyone seen cataract following TTT? Swati, have you seen any cataract following TTT?
Yeah, hi, Dr. Honavar. Hello, everyone. Sorry, I joined a little late. Yeah, so I usually follow, I think, as Dr. Honavar was pointing about the limit of the number of spots that we use. So I also follow that we use for 5 minutes or less, not more. I haven't used personally for more than 5 minutes to exactly comment if using more than 5 minutes would cause cataract or iris changes or any of those. With the 5 minutes of laser, so the settings that at least I use is like 9,000 milliseconds and usually 300 milliwatts power. And the maximum that I go on when I'm doing on a continuous mode, it's 35 spots, which is equal to 5 minutes. So that's the maximum that I go, and with that I haven't seen any cataract, but hard to comment if more than 5 minutes if it causes cataract.
Has anyone seen cataract or iris transillumination defects, Mahesh?
So this is your teaching, Dr. Honavar, that the color change should be a gentle graying of the tumor and never a white once you apply TTT. And around at a setting of 300 to 600 milliwatts and 9,000 milliseconds, the number of spots should not be more than 30. So this is what we have followed as your fellows, and I think that's the reason we've never seen a cataract following TTT.
Mahesh, have you seen any cataract or iris?
I have not seen any cataract. Actually, I have been quite aggressive. I have treated much larger tumors, multiple tumors, for even almost up to 10 to 15 minutes of laser photocoagulation. I think the cataract will happen if in case the iris absorbs the laser energy. But like if you're focused onto the tumor, I have hardly seen any cataract. So I have not seen any cataract, but I have been aggressive. I have treated much longer duration as well. Multiple tumors, post-chemotherapy residues, I have treated them much more aggressive.
Damage to the sphincter is a possibility if the pupil is small and the cone angle is, because the indirect ophthalmoscope diode laser has a slightly larger cone angle. So has anybody encountered sphincteric damage resulting in poor dilatation of the pupil in subsequent sessions?
I've certainly induced iris damage on very peripheral tumors when I've tried lasering them. That may be why in that first case, I'm also more inclined to do cryo because I know I'm not going to cause that. I use a 1.3 millimeter large spot size on a continuous wavelength, so I don't have to pick milliseconds or number of spots. It's just on. And I've certainly lasered for longer than 5 minutes. And I've never induced a cataract from that setting using an 810 nanometer laser.
Great. So we already talked about cryo a little bit. This is a nasal peripheral tumor. Size is 4 millimeter by 4 millimeter by 3 millimeter, 4 millimeter in diameter, 3 millimeter in thickness. Would you do cryo to this? And what exactly is the technique? Bhavna, do you want to explain? Bhavna is not, okay. Bhavna, I think your voice is not heard. We can't hear you, Bhavna. Anyone else who wants to start off before Bhavna sets her sounds? Correct.
Yeah, well, Dr. Santosh, peripheral tumors cryotherapy is definitely an option. So the rule is a freeze thaw of 3. That's what I use, and very rarely I go up to 4. So you need to freeze it so that you actually see a frozen wall over the tumor. I also prefer to have a little bit of freezing beyond the tumor as well, into the vitreous, and that's when I start thawing, and I 100% make sure that it's completely thawed before I go for the next freeze thaw cycle. So generally, average is triple freeze thaw that in my practice that I use. Very rarely 4 times I go for a freeze and thaw. Yeah.
There is some thinking among retina ocular oncologists who have a retina background that a gentler cryotherapy also works. Is that true? Mahesh?
If it's going to be only cryotherapy and the child is not on chemotherapy, then I would be treating the same way. I would want the ice ball to probably just come onto the surface of the tumor into the vitreous a little bit before thawing.
Yeah.
But there's a little bit of a borderline kind of a tumor because there is a possibility of over-cryoing this tumor, which can ultimately result in little breaks and vitreous traction. So if the child is on chemotherapy, then I would probably use a little less cryo, just about engulfing it and leaving it like that. But otherwise, I would treat it exactly like how Dr. Fairuz has just about discussed it.
We can see the scar size is much larger with cryotherapy. With the triple freeze thaw cryotherapy, you can see a scar becomes much larger, and that's not a major problem because we generally do cryotherapy for tumors that are in the periphery. But of course, atrophic retinal hole and rhegmatogenous retinal detachment are possibilities if you were to do very heavy cryotherapy and repeat it very often.
So Santosh, what's your maximum height limitation to do cryo? Because when I see something that's 3 millimeters, I don't know that if I want to do cryo or not. That's sort of pushing at my absolute limit for a primary modality. I'm curious what others feel.
3 millimeters is my cutoff. Any other thoughts? Height 3 millimeter, diameter you can possibly go up to 4 millimeter.
I think
I mean, for me, it's about 3 to 4 millimeters as well. So when I first looked at that picture, I thought cryo, I mean, really the upper limit of cryo for me. But you got great response from cryo, so that's very good news, really. Rather than, I mean, the other option would be plaque. So you know, it's it's useful, very interesting.
Dr. Santosh, can I have a question for the faculty here? Because we have all the experts right here. So if you have multiple peripheral tumors, let it be 3 or 4 or 5 tumors which are sitting in the periphery, which requires cryotherapy, would you go ahead and do cryotherapy at the same, like multiple cryotherapy in the same eyeball?
Yes, and I've done that, and I've been surprised how well that can work. But it's actually incredibly painful for the kid. Mm-hmm. So this is a child who'd got an only eye, so the other eye's been enucleated, already has systemic chemo, already had intra-arterial chemotherapy, and we were already given 1 cycle of 3 injections of intra-arterial chemotherapy, and yet there was relapses in the periphery in 3 or 4 areas, and giving the cryotherapy has worked for that child. We're still a couple of months out. So it is a useful tool rather than diving straight into IAC straight away, in my view.
This is a group B bilateral tumor, macular tumor. What would be your preferred management currently with all the modalities being available now? So what would be your preferred choice? 4-month-old child. Controversial.
Start with intravenous chemotherapy because 4 months old and it works quite well. And particularly in the right eye, the part of the disc is a little bit covered as well. So I would probably start with intravenous chemotherapy.
Yeah, I totally agree with Dr. Mahesh. Both eyes, it's kind of a foveal tumor. So it's not only about salvage of the eye. As a oncologist who's managing this 4-month-old, you're also concerned about the vision salvage in this child. So intra-arterial chemotherapy is definitely an option, but then we don't want to take the risk of bilateral intra-arterial chemotherapy and going for a retinal artery occlusion. So I would avoid, if at all, I want some vision salvage in this child who's bilateral for a systemic chemotherapy, definitely for vision salvage.
I think I'm also a strong advocate of intravenous chemotherapy in this situation.
Yeah.
I think this is a case where, at least in the United States, it's so depending on where you go. it's so dependent on which center you go to. You will have individuals adamantly say that this patient should get bilateral intra-arterial chemotherapy. In our hands, we would do systemic chemotherapy. I think many centers still do, but the voices that advocate for intra-arterial chemotherapy are so loud that many times families seek intra-arterial chemotherapy, misperceiving that intravenous chemotherapy is an old modality that has lost its value. And this is a real challenge in the field today. I completely concur with what's been advocated. And saying that intravenous chemotherapy may not be easy because the lower dose due to reduced creatinine clearances may impact the effect that you get. Sometimes you have to give much lower doses due to the body surface area of a 4-month-old. So it's not an easy situation, but it's fascinating to me how at a meeting like this, we can sort of get some uniformity in approach that many of us are advocating intravenous chemotherapy. But at a meeting in the United States, I think the discussion and the outcomes might be very different.
We have an oncologist on board. Vijay and Dr. Reddy, do you want to comment on this? A 4-month-old child, as an oncologist, would you prefer intravenous chemotherapy or bilateral intra-arterial? You're muted, Vijay.
Am I audible now?
Yes.
Thank you, Santosh. We did have reasonable experience in doing intra-arterial chemotherapy bilaterally. We have reasonable good results with this, and we hardly had any issues. We were a little skeptical while for the first case, but we are quite comfortable these days to do bilateral intra-arterial chemotherapy. The responses, better. There have been extremely good responses in these patients. So we preferably do intra-arterial in this patient.
From an oncology perspective, does it matter if you do bilateral intra-arterial versus standard dose intravenous?
The bone marrow suppression was not significant, not more than what we do unilaterally. So they were able to tolerate well. We didn't have any issues.
Okay. This child was treated with intravenous chemotherapy, and you can see extremely good response just after 1 cycle. And younger the children, better is the response, and that's what we have seen. So does anybody else agree with this, that younger the child, better is the response to intravenous chemotherapy or any sort of chemotherapy?
I agree. The younger the child, definitely it works very, very well.
Yeah, but if the patient can afford and the general condition is good, do you still consider this patient for intra-arterial, Santosh, and rest of the people?
My choice is intravenous unless the family is very keen on intra-arterial chemotherapy. Bilateral young child, where we know that intravenous chemotherapy works very well in a majority of patients. But if the family is already educated about intra-arterial chemotherapy and are insisting on it, well then, you can't refuse it because we have the facilities available, and we have excellent team who can carry on in bilateral intra-arterial chemotherapy. So I prefer intravenous, but I'm okay with intra-arterial if that is what is asked for.
Maybe because patient is too young.
Yeah, 4 months.
Yeah.
So specifically for the age, I think the intra-arterial will be quite a challenge from what we've heard. You can perhaps catheterize without the sheath. You can catheterize the ophthalmic artery, which we've started doing in Toronto in some situations. But I think by and large for a tumor like this, I would agree with everybody or the majority of opinions that we'd start with intravenous chemotherapy and not intra-arterial in this situation.
So age-wise, Dr. Ashwin, I just wanted to make a comment. Well, there's a case report that I have published. The youngest that I have treated was 37 days, less than 4 weeks. So in a good hand with an interventional neuroradiologist or a neurosurgeon, with a good learning curve, I think age, well, it's safe.
Is it with the sheath or without the sheath?
With the sheath.
I don't think the risk at the very young age has to do with accessing the vasculature per se. It's the potential for femoral thrombosis.
Mhm.
And so then the question is, how are they accessing things? Are they avoiding the femoral vasculature? Are they going through umbilical vasculature? But we know that the accessing those vessels are amenable at a very young age. It's those other potential toxicities, potentially putting a limit risk at the very young age, which we need to be thoughtful of. The other point is that we're all talking and saying intravenous chemotherapy, but there are many centers that at a very young age are very disinclined to give the etoposide at this young age. And there are centers that would give 2 agents, not 3 agents. And we can certainly go to the Children's Oncology Group protocol that looked at 2-agent chemotherapy and did have higher recurrences after 2-agent, but they were largely salvageable recurrences. So it's not a bad discussion to have. Do you give the etoposide? Do you not give the etoposide? At various points in our group, I've had pediatric oncologists feel strongly one way or the other, but it is something to bring up, especially in a bilateral case.
Question to Swati. Now we have excellent response just after 1 cycle of chemotherapy. Would you stop here ever, or would you try consolidating with TTT, or would you go on to complete 6 cycles?
Yeah, thanks, Dr. Honar. Before I answer that question, I just wanted to bring out one other point, probably hear what others think about it. So there is also a thought process and also publications that suggest that systemic chemotherapy in bilateral cases also offers protection against second cancers and pinealoblastoma and probably even metastasis. So any comments on that? How many of you believe that this is true? Does it have any effect? Anybody wants to comment on that?
That paper comes from Anna Meadows that strongly advocated the use of 3-agent chemotherapy to prevent pineal tumors. And there are a number of us, myself included, who question whether systemic chemotherapy is actually preventing pineal tumors, or is the absence of administration of radiotherapy compared to historic control really the issue at hand. And what I would say is that we'll be presenting some data at ISU in June, so I hope you can all come, suggesting that there is no protective effect from systemic chemotherapy as it relates to pineal tumors. But I think increasingly people question that, but that is certainly one reason why some strongly advocate systemic chemotherapy in a child like this.
Yeah, thanks for the comments, Dr. Gombos. Yeah, I think as rightly pointed out, I think it'll be interesting to listen to your data when you present this June. So so coming to the question whether I would continue chemotherapy or any consolidation treatment in these cases, certainly I would complete 6 cycles of chemotherapy. We follow the protocol-based treatment and complete 6 cycles of chemotherapy, irrespective of even if the tumor has completely regressed after just 1 cycle or 2 cycles of chemotherapy. Whether focal treatment would be given, that will entirely depend on if there is any non-calcified part. Sometime, like for example, in the right eye, we see that there is some non-calcified part in the inferior portion around that calcified area. Probably I would just do TTT as a consolidation treatment there. For the left eye, I would just observe. Just based on if there is a non-calcified part, then I would probably do, otherwise no treatment either.
I joined back. So what is the best time to start focal consolidation, Bhavna? What do you think? After starting intravenous chemotherapy, at what cycle would you start focal consolidation?
So I hope I'm audible now.
Yeah, very much.
I've switched to a new device. So yeah, thank you. And answering your question, I would wait for until 2 cycles of chemotherapy. So the protocol that we generally follow for these kind of tumors is that we start with systemic chemo reduction, and after 2 cycles of systemic intravenous chemotherapy, we do an EUA, and on that EUA itself, we start focal consolidation treatment. And as Swati said, I completely agree. I would go for a total of 6 cycles, even if the tumor is showing almost near total regression. I would still continue 6 cycles, and every 2 cycles of intravenous chemotherapy, I would like to do a TTT in both the eyes. until the completion of 6 cycles. And thereafter, it would depend on our EUAs. We would stop systemic chemotherapy, but if the tumor shows any signs of recurrence or, any, if there are new tumors in the eye, then of course we would treat them differently.
Ashwin Reddy, would you?
Yeah. So it's a good point to jump in now. So the question is, you're doing chemotherapy and laser for macular tumors. So we try to address this. Dan will know, John Hungerford was not very keen on doing laser therapy after chemotherapy. So we kept that in London, and the team in Birmingham would do it just as you guys are doing, laser with chemotherapy. So we actually had 2 centers in the same country that were doing things differently, and that's really useful. And I think that sometimes something we have to just be aware of. Unless we've got definite black and white, it's good to do things slightly differently to see if it actually makes a difference. So actually we looked at this, we published it in British Journal of Ophthalmology a year or so ago, and we looked at our patients who had macular tumors, had chemotherapy. So in London, we would tend not to do laser. And in Birmingham, they do what you were doing, which was focal therapy, Philadelphia salt therapy, basically giving chemotherapy and laser at the same time. And we didn't tend to do laser because we were worried about the vision. That's why we wanted to avoid laser. And we looked at these 2 groups and we compared. And what did we find? Well, we found the chance of relapse was the same if you'd done laser beforehand, what we call prophylactic laser, which is what you're talking about when you're giving chemotherapy and doing laser. And if you've done no chemotherapy, but also the vision was about the same. So actually you could take both approaches. So that is it's not great evidence, but it's some evidence that, when you do your laser, if you do your laser, is still up in the air. And probably we need bigger studies to show whether laser is actually relevant or not. Because essentially, if you're going to go get a relapse, you have one cell that is going to relapse, and that's going to cause a clone, and you don't know where that is. And so the approach of just giving chemotherapy and watching, and then when you find the clone, lasering that area, that's fine, and that's what we do, rather than the prophylactic laser. So we published that in BJO.
Dr. Ashwin, I have a question for you.
Yeah.
So what would you do if there is a recurrence after the 6 cycles of chemotherapy? Would you do more chemotherapy or would you do laser?
Do laser. It depends on the size of it. So what you're talking about here, what Santosh's question is, giving the chemotherapy and doing laser at the same time, when we not sure if that fish flesh is inert tumor, and we know that inert tumor exists. We can't flatten all tumors to a flat scar. That's not going to happen. We know that exists. So is that inert tumor, or is there a cell in there that can cause a relapse? So that's his question. So when we see the relapse, we treat it. That's a scenario. So what's the advantage of not doing so much laser? So this issue about cataract formation, doing lots of laser. Also, the number of EUAs. Some people would do a laser after each cycle of chemotherapy, particularly if you're giving 6 cycles. So it has an impact. But, we tried to address that in a study with a group in the UK.
Do you have a
comment? Yes, sir. I totally agree with Dr. Ashwin from London. So especially in this particular case, since it's a macular tumor involving the fovea, I would definitely not touch it, up until the cycles of chemotherapy is completed, because, that's what you're aiming at, a total complete regression with the chemotherapy. And as Dr. Ashwin rightly pointed it out, there is definitely a fish flesh there, but you really are not sure whether it's an active tumor, or it's, you know, a well-differentiated portion which is lying there. So we have to be very cautious when it's very closer to the fovea, because laser to an area can even cause RP changes. We have seen in our practice, even, you know, adjacent to it and remote to it. So something which is a foveal and a macular tumor, definitely I wouldn't, you know, take laser until the chemotherapy cycles are completed, at least minimum of 4 cycles, and then decide, depending upon, you know, the nature of the appearance of tumor in subsequent EUAs to take up for TTT. Yeah, thank you.
Sumit and Seema, you haven't spoken. Do you have any comments? Jess, do you have any comments?
No, Dr. Santosh, I think this is exactly what we follow. So 6 cycles, complete 6 cycles, irrespective of the regression time and the status of the tumor. And laser only if required, and only after about 2 to 3 cycles, not before that. And not wait till 6 cycles and then start laser for the recurrent tumors or the residual tumors.
Ashwin, do you have any comments? You have
Yeah, just the last comment there to say that we usually wait for chemotherapy to complete before we start focal therapy of any sort. If or not you start focal therapy is a debate that's different. But I think if treating a tumor with focal therapy is going to cut off its blood supply in some way, then there's not enough access to the tumor to chemotherapy if you're treating it parallelly. So I think we tend to finish chemotherapy for that reason as well, in addition to waiting for the maximum consolidation. So all cycles of chemo, and only then, if needed, focal therapy after.
This is a situation where an 11-day-old child at presentation was treated with 6 cycles of intravenous chemotherapy for bilateral retinoblastoma. Right eye, this is the residual that we have after 6 cycles of chemotherapy, a macular residual. So how do you go about it? Anyone can answer this. Mahesh?
Well, I think in 11 days, you always have these patients that are very treatment resistant. These very young patients are sometimes actually some of the hardest, because these small tumors can be really difficult. I know that there was approached in London to watch a lot of this fish flesh after therapy. But if this isn't the remaining eye and the other eye has good visual potential, then I'm more inclined to laser that. And I think what the difference is just a comfort level of how the practitioner feels. Are you going to feel comfortable just watching that, and for how long? Or are you going to be anxious in a particularly younger patient? You know, let's say you can't control this with thermal therapy. You know, what's going to be your next step? And so if I've already initiated intravenous chemotherapy on a child, I'd like that to be resolved. And but it's you know, the other eye is a big factor for me, whether I'm going to treat that residual gray material in the macular papular bundle, or whether I will try to consolidate with laser.
Mahesh, do you have any thoughts?
Yeah, it's responded very well, but then still we do see some vasculature within, though the feeder vessels have become smaller. And I would agree with Dan that I would also probably be comfortable treating the central fish flesh kind of an appearance with the TTT. I wouldn't want this to come back because it is sufficiently away from the disc. And I would not treat the calcific residue all around, but I would probably treat the residue in the center with TTT.
Anybody?
Dr. Santosh, I have a question for Ashwin from Toronto here. If we can go back, yeah. Since Dr. Ashwin spoke about how OCT is useful in these, tumors to assess their activity and, treat further. So, Dr. Ashwin, would you use an OCT to assess this and then take a decision? Like, what's the way?
I think in something that's this large, some of the assessment can be done just grossly as well. But I think even assessing your laser response, it's very, very useful to do it with the OCT. So we can be more precise to to ensure that the laser has only fallen within these confines. The other thing is there may be I don't quite see exactly where the fovea should be over here, but it might be in the edge of the scar. If it's in the edge of the scar, then you also get to identify exactly where the fovea is and try and avoid that for lasers or that area for lasers as much as you can. So there are, you can be more precise with an OCT, yes.
Would anybody consider plaque brachytherapy at all in this situation? That's what we did, but of course, it's a matter of opinion.
Yeah.
Santosh, with the plaque brachytherapy, you're basically losing the vision, right? Any opportunity for vision?
Not necessarily.
Is this a ruthenium plaque? Because it's vastly different from the iodine-only plaque that Canada has.
Yeah, this is ruthenium and a low-dose brachytherapy. This child was treated with 4,000 centigrade. And there was no radiation retinopathy. It did well, and there is, you can see that around the lesion, RPE looks good. So the child is not old enough for us to assess vision accurately, but after intravenous chemotherapy, plaque works better. But after intra-arterial chemotherapy, we had major issues with plaque brachytherapy, higher incidence of radiation retinopathy and vitreous hemorrhage and stuff. So,
can you also
this
make a
is
comment
at the
on
macula, right, Santosh? Santosh? Yeah, a plaque right at the macula. Okay.
So can you perhaps make a comment on the difference between radioactive iodine to ruthenium in this particular situation? Would you ever have chosen iodine if you had it?
Iodine, I have had no access to iodine. I've never used iodine except during my fellowship. But I think Carol is yet to join. We can ask her. She'll use it regularly for macular residual or any residual tumor which is refractory to other trips. For example, this patient, if you're done, say, several sessions of transpupillary thermotherapy and then still the patient had a residual lesion, finally you'll have to come back to plaque. So maybe you can avoid the number of sessions of, just an argument, sessions of laser TTT by doing a slightly premature plaque, if you may call it.
So Dr. Mahesh has good experience with the iodine plaque, I guess. Maybe he can comment on that.
I was using iodine earlier in Shankanet earlier, but last 10-15 years I've been using ruthenium. And most often the iodine is for the melanomas because of the thickness and macular tumors. Yes, earlier days I used to use, but I can't say that comparison-wise, I don't really have an experience as to what works better or what results in more complications.
So I'm one of the few centers in the US that has ruthenium and iodine. And I would say I generally much prefer ruthenium for almost all circumstances, certainly RB and local recurrences of RB. But it's interesting when I look back at my experience with John Hungerford, who also had iodine and ruthenium. He preferred iodine for certain retinoblastomas because he could control the dose rate. And that, of course, is something we generally don't control with ruthenium because we let it decay over time. But he was much more in tune to dose rate. So here again, the subtleties of not only, when we just talk about plaque, it's not only the source, but it's also the dose and the dose rate. There are other aspects that contribute to toxicity that we often don't elucidate as we should. But it was always interesting to me that Mr. Hungerford would often prefer iodine in a center that was very heavily ruthenium based. For RB.
Santosh, if I can comment. Yeah, so the only advantage in terms of the effect on the tumor, whether it is iodine or ruthenium, it's the same. But, as you rightly said, the differential dose is possible with iodine because you can place the sources based on the tumor burden in different areas of the plaque. So you can get a differential dose variation that is feasible with iodine, whereas with ruthenium, it's a uniform dose distribution. And again, the dose rate can be adjusted with iodine, where in ruthenium, you cannot. So that's the only advantage. But otherwise, the effect of the radiation, either with iodine or ruthenium, it would be the same.
What about the difference in the fact that one is a gamma emitter, an X-ray emitter, and the other has a beta emitter? I inherently think that
Yeah.
It seems to impact the tissue. I'm curious how others who've used both modalities in RB would respond to that question.
Yeah, so as I said, the radiobiological effect remains the same. Distribution varies because one is gamma, the other one is beta. So the tissue, the deeper tissues might have little larger doses with radioiodine therapy, the iodine plaques versus ruthenium, whereas immediate dose decay happens within few millimeters.
Fair enough. So this is a patient where there is what looks like a well-differentiated tumor. After 6 cycles of intravenous chemotherapy and TGT, this was the residual tumor. So would you have treated at this stage, or would you have just left it alone?
Left it alone.
Okay.
Hi, Carol Shields here. We would have left it alone too.
Mhm.
Hi, Dr. Carol.
Thank you for
Hello,
joining.
Dr. Farouz.
Hi.
This looks like a cavitary retinoblastoma, and
Right.
it looks regressed. There's always that temptation to do brachytherapy. It would be uncommon for it to recur.
Mhm. You just watch it
Absolutely.
periodically, and then
And even over the time, Dr. Santosh and Dr. Carol and everyone, even this cavities kind of change, whatever rim you see there, it kind of comes smaller and the cavities sometimes enlarge. So yeah, definitely observe.
Yeah, some disappear, some appear. So,
Yeah.
but I think so in our study, the relapse rate was less than 10% for cavitary retinoblastoma. So you didn't have to laser the hell out of them.
right. This sort, after 3 sessions of intra-arterial chemotherapy, would you have left it alone, or would you have lasered it? This is how we began with. This is after 3 sessions of intra-arterial chemotherapy. Further went on to give intravenous chemotherapy, and this is the final appearance. Would you have left it alone at this point in time? Anyone?
Can I take that, Dr. Honavar?
Sure.
Yeah, I think the third picture, the post IAC picture, probably at that stage, if we know that surely there are cavities, and if we can document the photographs each time and just compare, I think that's always very helpful, especially with cavitary RBs. Because if it would be, if there are cavities and if it remains stable, so we know for sure that it is not progressing, probably we may not have to do even intravenous chemotherapy.
Yeah, but then there are fleshy areas which seem to have responded following intravenous chemotherapy, and the number of cavities have increased. So does it mean that at this stage we still had a viable tumor that would have responded to chemotherapy? Or is it hypothetical?
I think even say for example these patients, if we do TTT, it'll obviously become a flat scar, in certain areas at least, but that may not necessarily mean that it was active. So I would still think that documenting these with serial photographs and just comparing each visit may be what I would do in such cases. And if it is progressing, then yes, we would think of alternate treatment. But if it remains the same, then we know that it's regressed.
What about this? This patient, 11-month-old male child, right eye groupie with cyst, treated with intravenous chemotherapy, plaque brachyation, and vitreous hemorrhage with necrotic tumor. So how often do you find brachytherapy following intravenous or intra-arterial chemotherapy, abnormal response to brachytherapy? Finally, it settled down, of course, but this was a very abnormal response. Have you seen it more often with intra-arterial chemotherapy, or do you see it with intravenous chemotherapy as well? Following chemotherapy, doing brachytherapy, does it have more complications than doing primary brachytherapy?
Yeah, I would think there are more complications. And, after brachytherapy, little tiny ischemic vessels occur on the surface of the tumor, and any amount of, vitreous traction or movement can break those little vessels. And we've seen patients with repetitive vitreous hemorrhages that can be, difficult to manage because it's not neovascularization. It's regressed tumor vessels that are just getting tugged at. And brachytherapy causes PVD. So we're inducing PVD in these kids at a young age. And, this is creating a little bit of vitreous hemorrhage. We'd probably, hopefully, let that settle out.
I think we are running out of time here, but just the last one. This was a patient with, let's go to, yeah. How good is intra-arterial chemotherapy for vitreous seeds?
Yeah, I think Dr. Carol can take that question.
Yeah, I mean, it depends on how dense the vitreous seeds are, but we talked about this recently in a webinar. We don't give any intravitreal chemotherapy in a patient who's getting intra-arterial chemotherapy. We wait until at least the first dose is given, because you might be surprised that all the vitreous seeds go away. So you don't have to give intravitreal chemo. I would say on average, IAC can control maybe 50 to 60% of the cases with that have vitreous seeds.
So similar, I have seen vitreous seeds being controlled with IAC. Yeah, so just wait for 3 sessions and then decide whether you want to go intravitreal.
So there we end. I think with this panel discussion, we have created some controversies which we hope to address in the didactic sessions, which will be more clear-cut, I suppose, in terms of giving answers to specific questions. So Dr. Gombos has another commitment. So he would like to go first, and he'll speak on screening of retinoblastoma. Dan, you can share your screen. He is the current president of International Society for Ocular Oncology, and he's from MD Anderson Cancer Institute.
Santosh, if I can make a last comment, please.
Yeah. Go ahead.
Yeah, so the one more other difference which I wanted to mention about the plaque brachytherapy with iodine and ruthenium. If you have a thicker tumor, more than 7 millimeters, so it's preferable to go for a iodine, which is better in dose distribution compared to the flat tumors. So flat tumors, you prefer to go for ruthenium. So that's an advantage of a gamma radiation. But again, I repeat, the effect of radiation would remain the same.
So we'll go with Dr. Gombos, and the discussant will be Dr. Sumit Lahane from JJ Hospital, Mumbai.
Thanks. Can you just confirm you can hear me and you can see my slide?
That's right.
Thank you. Well, it's always an honor and privilege to be at the All India Ophthalmology Society meeting, and I'm very grateful for this opportunity to speak to you today. My assigned topic was screening in retinoblastoma. Do we have consensus? And for those who don't have time to hear the answer, let's just get straight to the answer, which is maybe, sort of, kind of, well, yes. And I would argue it's always fascinating to see if we can ever truly find consensus in anything in retinoblastoma. But I've been very pleased at the screening and the consensus that we have developed over time. This is our center in Houston. This discussion at some level happened with the publication of this paper, which many of our colleagues are on this talk. It was a screening manuscript that we published in the Journal of Ophthalmology. And while there were a number of colleagues who were on this paper, I'd really like to highlight the role of Alison Scallett, who really motivated many of us to get this paper and its contents in publication, and Dr. Chavez Barrios at Houston Methodist, who spearheaded this. And the concept of having sort of guidelines or screening parameters is not new. I remember being a medical student working in New York City and saying, is there a published mechanism by which we can, screen patients? And of course, we know that there are patients who absolutely, benefit and need screening. These are patients with a family history of retinoblastoma who, compared to the general population, have an elevated risk for this disease. And we know by consensus that if we diagnose this disease when tumors are very small, we absolutely and reduce the need for more invasive therapies, whether it's intravenous, intra-arterial chemotherapy, enucleation, or radiation. But then the question arises, and this is how this paper developed, when and how do we screen? And that was really the question that Dr. Scallett asked many of us, Dan, how often do you do it and when? And then, of course, why do you do that? Which for many of us is, well, this is how the person who trained me taught me, so this is what I do. But there were many factors over the years, and even I remember these things coming up when I inquired as a medical student nearly 30 years ago, why didn't we have such a document? Well, first level, people are not keen on having, quote, guidelines per se. They're very concerned that if a guideline says that at age X, you need to do this test and it's not done, it opens up the practitioner to litigation. And so there's enormous hesitancy at that level. Then there was the concern raised, well, we may have certain approaches that we may prefer in certain centers in North America and Europe, but there are enormous challenges in following certain recommendations in rural areas and lower middle income nations. One example of which is access to skilled pediatric anesthesia, which in some countries is quite dangerous because there's very little access to pediatric anesthesia for exams under anesthesia. And then finally, we wanted to make sure that if there was such a document, it wasn't just based on what people did, but that there was a scientific basis for what we were doing. And so that became the goal of this concept, was to come up with a consensus paper. But I would point out it was a consensus paper to try to provide guidelines for screening in the United States with the primary goal of early detection. This is not patients who are already undergoing therapy. These are patients who are at risk and therefore have an early detection approach. And it should be scientifically based as much as possible. So we created a consensus panel of the individuals you saw. And our first approach was to say that we were going to use risk stratification. So this is common in cancer medicine, where we administer screening based on risk. And those patients who are at higher risk are more likely to get screening than others. And we know very clearly in retinoblastoma that we can individualize that risk with genetic analysis, both testing and counseling of the family. And I will always say of the family, because in retinoblastoma, this is a disease not of a patient, but impacts everyone in the family. So one clear area where we were able to get certain consensus, and I don't think this is room for disagreement, is anyone who's at risk for retinoblastoma above the population risk should have some form of screening with a dilated exam by someone with experience in retinoblastoma. We didn't want to limit that to ocular oncologists. So we opened that up to all specialists who can perform and know what to look for. And we recommended frequent screenings, particularly young age, because we know that those highest risk patients are at higher risk based on age development, that tumors decrease in frequency over time as the child gets older. But we also strongly advocated genetic testing and counseling. Counseling being just as important as testing, I might add. A lot of times patients just get a test, they don't know how to interpret it. And the other thing we point out in the paper is that genetic testing should be afforded to patients who have unilateral or bilateral disease. And just this week, I learned of families that are getting miscounseled because some practitioners said, well, your child has unilateral disease. They don't need to be tested for the genetic form of this disease. Completely not consistent with good care. The next thing we did is we just took some base scientific information of what we know. And what we know is the risk of retinoblastoma, even without genetic testing, just on proband analysis, such as this. So if you take the proband, you know whether it's bilateral or unilateral, you can identify the relative risk in a very simplified model and identify it as high, intermediate, or low risk. This requires no genetic testing. This requires just family testing. We decided that particularly the high and intermediate risk children would benefit from a more intensive approach. But we can't deny that in 2022, genetic testing plays a significant role. And I think most centers, if you're going to call yourself a center, you must involve genetic testing. You must involve counseling, because the impact of a family, if a child is RB1 positive, and then a family member is tested, can be the difference between no screening or quite aggressive screening. And it's still sad that in the United States today, we still fight for genetic testing with some insurance policies. And another goal of this paper was to support genetic testing. So the group came together, and this is, of course, where it's a little less scientifically inclined, but there was an attempt to try to stratify between high, intermediate, and low risk. And of course, this came back and forth between the team, but a general consensus developed that you can see here, and this is ultimately what was published. We tried to determine between sedated and unsedated and sedated exams. And we certainly concluded that risk stratification is a beneficial approach with refinement of genetic testing. And I would point out that the schedules that we listed are general guidelines. We left it up to the primary practitioner to decide ultimately what they were going to do. We did not write a preferred practice pattern because we didn't really have the data for an absolute preferred practice pattern, but we certainly recommended exams under anesthesia for any child who is unable to participate in an office-based exam or to allow thorough examination of the retina. Well, what's been some of the feedback? Because you asked me if there was consensus. Some of the feedback's been very positive. It gives certain practitioners, particularly those in some rural areas, a much greater structure and template for follow-up. It allowed for justification of EUAs, and as many of you know, we had significant challenges in getting patients to the OR during the pandemic. We had to justify each and every patient at our hospital who was put to sleep during the height of the pandemic, and papers such as this justified the role of screening high-risk patients because of the risk of disease. And we justified the role of genetic testing and counseling with insurance providers, including those with unilateral retinoblastoma. And the fact is, we had enormous endorsement from the highest levels of the societies listed here, including the American Academy of Pediatrics, Ophthalmology, and the Society of Pediatric Hematology and Oncology. So I think that in and of itself speaks to the consensus nature of this manuscript. But there have been negative comments made, and I'll point them out. They've been published. What is the duration of which we need to screen? And some individuals, and I would advocate this, is that at some level, any child with retinoblastoma should get an exam every year. It doesn't need to be an EUA, but it needs to be an office visit and a review, especially if they're unilateral or they're ultimately going to have family members of their own. There's certainly utility in doing an office visit. When should you stop doing exams under anesthesia? That's been the most controversial aspect of this manuscript, with our European colleagues, particularly in the Netherlands, advocating that we recommended stopping EUAs up to the age of 7, but there are many centers who do that at a younger age, and there's some data to suggest that it's not unreasonable to stop at maybe 4 or 5 years of age, and that's an open and valuable discussion to have. And then some centers have argued that we shouldn't have risk stratified, although again, very commonly used in cancer management, that you're either at risk or you're not at risk. So my final slide here, is there a consensus on screening? When it comes to the valid points, absolutely yes. We need to stratify our highest risk patients. We need to offer them genetic testing and counseling. EUAs, if they can be done availably and safely, should be done. And the highest risk patients should be seen early on and frequently. And I thank you for your attention.
Thank you very much, Dan. Very wonderfully summarized. Very nice talk. Sumit, do you have any points?
Yes, sir. Yes. So, good evening, everyone. Dr. Dan, that was really nice talk, and we went through your paper. It's very beautifully done. Thank you for giving us some insight about the screening, sir. I have a few questions where you have risk stratified and given them as a higher, intermediate, and the low risk. So, should we have any algorithm instead or along with that, like where like genetic testing is not so frequent in India? For certain countries, it may not be very possible, or many times even the parents are not so willing. Could be a cost thing or other bars, because of which it is difficult. So can we have some algorithm regarding that, where we can do certain steps and then plan for screening?
Yeah, absolutely. If you look at the slide that I showed with the genetic tree, that high, medium, and low risk is based without any genetic testing at all. So the reason we put that in is because we understood even in many high income countries that genetic testing is sometimes an obstacle because providers won't pay for it. So that's sort of a national issue. And we certainly know that, there are going to be some patients that have up to a 45, 50% risk of disease. Those patients should absolutely be at the highest level of the tree. But then you do have this sort of cohort that's above 1% and, less than 10%. And so how do you find that balance? And so we sort of lump that in, but, we have to be cognizant of the resources in any particular environment. And that's why I think we sort of put it at the highest, medium, and then lowest risk. I think you could argue if there are really significant limitations in resources, and we saw how the pandemic significantly impacted resources, that you have to stratify those patients. So again, I think just, whether bilateral, unilateral, family member, proband, that you can get a lot out of just that basic information. And if you don't have a geneticist, then that risk stratification falls on the ophthalmologist.
And sir, do you recommend, like, it's a consensus that we have come through across the experience of multiple centers in the United States and other countries. So should we have any follow-through study following the guidelines that has been given in your article, and then try and give a preferred practice pattern? As you said, these are not a preferred practice pattern, these are guidelines. So can we go ahead, one step ahead in what primary work have you done?
Yeah, I've had very nice discussions with Alison Scowlett, and we took to heart many of the comments that have been published by people like Annette Moll and David Abramson, and there's certainly an opportunity to maybe improve on these things. I think particularly this age between 5 and 7. Both I and Matt Wilson have seen retinoblastoma in a screening patient above the age of 5, and it just happened to me within the last 2 years. So after 21 years in practice in Houston, I never saw it. Matt Wilson said he had seen one. So this is sort of my anxiety about that rare between 5 to 7 age range. But there are others. And again, Annette Moll has really good data from the Netherlands to suggest screening under anesthesia for that age may be a little bit too much. And I think that's a valuable point to perhaps circle. We should not be so wed to these recommendations that we can't be open to improving them and modifying them further.
So one last question from my side. So how do you rate, or where is the place for ultrasound in the screening program, where this EUA is little not acceptable to everyone? So does the ultrasound hold any place?
I know that Lynn Murphy was a big advocate of office visits, combining ultrasound in cases where he could not do exams under anesthesia. I have never felt comfortable an infant without looking at the retina and documenting it and going around and doing a 360-degree exam. But certainly if one is in a situation where for any enormous reasons they cannot perform an exam under anesthesia, an office visit augmented with an ultrasound is certainly better than an office visit not augmented with an ultrasound.
Thank you so much. Thank you, Dan, for sparing your time, and Sumit for your wonderful discussion.
I appreciate it. I look forward to coming to India again.
Thank you so much. We move on to Ashwin Reddy to speak to us on what's new. What new am I doing in retinoblastoma in 2020? Ashwin, over to you.
Thank you. Can you see my slides?
Yes.
Excellent. Thank you very much, Santosh, for inviting me. It's always a privilege to be part of this meeting at the All India Ophthalmological Society. So you originally asked me to say what's new in 2022. I thought I'd just change it a little bit into what I've learned in these last couple of years with a few cases. So I always show this picture of nearly 20 years ago when I first met Santosh. I just done my fellowship and I just come over to India to see what he was doing in Hyderabad. So that's the first time, and we've been in touch ever since. So the first case I'm going to talk about, it relates to vitreous seeds. And before I start, it's just important to know where we are in London. So we've had actually quite a few tragedies in London over the last few years. About 5 years ago, Judith Kingston, our pediatric oncologist, passed away. And we renamed the retinoblastoma unit after her. And at the inauguration of this unit, Vicky Cohen, who's at the front here, and John Hungerford, this is just the back of Vicky there, and John Hungerford came for this inauguration. And as we all know, sadly, Vicky passed a couple of years ago and John passed last year. So this family here that we have here, grandmother, mother, and child. So the grandmother was treated by John's predecessor, Mike Bedford. The mother was treated by John. As you can see, she's got had external beam radiation therapy. And a little girl here, Keris, she was treated by myself and my colleague Mandeep Sagu, and she's got both eyes and sees well with both eyes. So this is the Royal London Hospital, and this is where we treat retinoblastoma in London. It's the oldest medical school in England, and this is a picture from the 1750s. And during the lockdown, it became a COVID hospital. As many of you will be aware, in March 2020 in the UK, a lot of hospitals were commandeered to be COVID hospitals. And this hospital has a very large ITU. So those of us who were still healthy, we were helping out in intensive care in 2020 and 2021. Mind you, the last time I did general medicine was about 30 years ago, so I'm not sure if I was that helpful, but about a third or a half of the nurses were all ill from COVID or something like that. So we were just more for morale more than anything else. And I was checking eyes out, which was much more in my comfort zone after the nurses started coming back. So Royal London becomes a COVID hospital. So where are we going to see our retinoblastoma patients? And that's where Moorfields comes in. So I'm a consultant at both places. So I spoke to the team at Moorfields and shifted the RB service there. But this is mid-2020. We didn't know much about COVID. And that brings me on to my first case. So this is a 1-year-old, mixed race, white and South Asian. And you can see the cavities here, right eye, macular tumor, just had systemic chemotherapy, cavity retinoblastoma. We didn't do anything else to that eye, no laser, no nothing. And it hasn't changed at all. Unfortunately, the eye that we're going to be talking about is this eye, which can see. And this has a cavity retinoblastoma. And unfortunately for this, there was relapse. Which is unusual, less than 10% when we've analysed our cases. And we gave laser, we cryo, we had to give intra-arterial chemotherapy, and that settled things down for a couple of years. But of course, during the lockdown, you can see these 3 seeds here. See that one there? 3 spheres appeared. And we were trying to minimize our aerosol generating procedures at the time. So these are spheres, type 2, vitreous seeds in the vitreous. And so we had to give an injection of intravitreal chemotherapy. So we give a mixture of melphalan and topotecan, 30 micrograms melphalan, 20 micrograms of topotecan. And of course, in India, you use topotecan virtually all the time. And some units just use melphalan. So we did 1 injection and then checked after a couple of weeks, and it cleared. The 3 seeds are cleared. So we thought, great, we don't have to do more AGPs. We can use ketamine, which is a non-aerosol generating procedure to see this child. Unfortunately, after 4 months, there was a recurrence. Seeds reappeared, and we used our usual mixture, which is those drugs 3 times, 3 weekly. And after the 3rd time, there was no evidence of vitreous seeds, so we stopped. Then it happened again, this time after 4 months of an assessment. Again, we used the same mixture, and again, after the 3rd injection, it had all gone. The 3rd set of injections. So we're doing this 3 times, 3 weekly. So the question is, where are these seeds from? I always thought if there was retinal seeds there, vitreous seeds, they'd be from the retinal tumor, or the retinal tumor was still creating the seeds. Or are these resistant seeds, which wasn't a concept I was familiar with. So I spoke to Francis Mounier, who's speaking at this meeting about this. And in very generously discussed this case. And his thoughts, which I agree with and which I'd like to highlight, was this is actually resistant seeds. So we should change the dose and change the frequency related to just giving one injection early on. So we changed it to 32 micrograms, topotecan, which Santosh, you published on. And instead of giving it 3 weekly, which was in your paper, we've given it weekly 7 times. And these seeds here went away. However, when we saw again after about 3 weeks, we found another sphere. So after consensus discussion in UK with our colleagues in Birmingham, we're doing 30 micrograms Malphilan and 32 micrograms topotecan weekly 4 times. So what did I learn? So you can have this concept of resistant vitreous seeds if the seeds are undertreated. Don't give one injection. So I'm used to having lots and lots of seeds, but if you're just seeing a couple of seeds or 3 seeds, you're very tempted, especially if it's the only, well, one eye that can see, to minimize the Malphilan input. So, or any complication from IVC. But that was a mistake because we just got a lot of resistance. Giving toxic drugs when no activity is seen, the consolidation, some units use that. And in this case, that may have been a good idea. And the morphology of the seeds, perhaps we should do weekly for spheres rather than 3 weekly for spheres and 4 times a day. But we have been using this technique for several years, and even for spheres, it's worked pretty well. Okay, the second case, case 2, bilateral advanced retinoblastoma. So this is a 15-month-old girl, and this is a case we sent to European centers to see what they would do. So we got reasonable vision in the right eye. This is, you can see here, shallow retinal detachment, tumor superior, tumor inferior, with vitreous and subretinal seeding. The left eye is the interesting one. We've got booth-thalamus, we've got raised pressure, we've got a large horizontal corneal diameter. So as Ashwin will speak about, the AJCC, this is CT2B or D, right eye, and CT3C, E, left eye. MRI doesn't show anything particularly alarming. So really, what would people do in that scenario? Would they enucleate the left eye, which is something we've been doing for years, but should we continue doing that with the risk of bilateral enucleation in advanced retinoblastoma? So we've done a survey. This is just the preliminary studies results so far. We were still waiting for a few studies in Europe. And you get it's half-half. Half the services in Europe are would suggest systemic chemo for this, and half primary enucleation. And it doesn't seem to be relevant, the size of these centers, which I found was really interesting in this sort of scenario. And I know there have been publications. I think, Santosh, you published on salvage of these CT3CIs. And finally, a case of pseudoretinoblastoma in a 2-year-old. And I'm not sure if you've seen a case like this. It's the first time I've seen this case. So this is our 2-year-old, and we've got an abnormality at the macula here, and we've got these lumps. This is elevated lumps here. And in the left eye, this is a better seeing eye. And again, you can see these lumps. Here we go, all over. No vitritis at all. It's not retinoblastoma. But then what is it? And my fellow said, could this be a genetic condition? And my thoughts were, well, for a genetic condition, I've never seen the elevated lumps associated with this. But she was right. This is autosomal recessive bestrophinopathy, and we found the pathogenic variants there. And this is the youngest in the literature, and these lumps will flatten. So the ones that I've seen in the older patients, VMD2 associated or BEST1 association, they're flat. So it's really interesting seeing these kids really early to watch how these flatten out. So, and finally, what are we doing differently now? So cell-free DNA, Jessie Berry will speak about that. we're taking aqueous from when we do IVCs and enucleations, and we're sending them to colleagues in Birmingham. And we're taking blood where we're working with Bhavna Chawla, the discussant here at Ames, in a multi-center study looking at cell-free DNA. So thank you for your interest.
Thank you very much, Ashwin. Nice, very nice learning points. Bhavna is ready to discuss.
Yeah, thank you, Ashwin. That was a wonderful presentation and great insights on some very interesting and challenging cases, all three of them. Couple of questions, talking about case one, where you modified the way you kind of normally give intravitreal injections. You first talked about giving both melphalan as well as topotecan. So do you know, I mean, like, is this normal? You normally give both these drugs together simultaneously? I mean, how do you administer these two drugs together?
Yeah, very good question. So we used to give, back 10 years ago when we started this, we used to give melphalan only weekly. And then over the years, we've changed a bit to 3 weekly. And now we're doing both drugs, melphalan and topotecan. So we give the melphalan first, and we've been doing this for the last 5 years. Then as it comes out, we're giving the cryotherapy. And then in the same area, we're giving topotecan. The needle in the same area, giving the topotecan, and cryotherapy as the needle comes up, and a final cryotherapy on that spot. So the purpose why we changed from melphalan only to melphalan topotecan was to try and prevent recurrence of vitreous's. The case I'm talking about is a very unusual case where we only gave the 1 injection and caused this resistance issue. But it has worked pretty well for spheres and dust. We haven't had any clouds for the last 3 or 4 years, for the last 4 years since we've been using it.
Very nice. But do you think giving these both injections, do you normally do a paracentesis? Because obviously the volume of, drug that you inject into the eye would be more than what you would do with 1 injection. So do you normally do a paracentesis for such cases?
Absolutely.
Or even drug?
Yeah. Absolutely.
Okay.
And that's when we do the paracentesis, that's when we're taking the aqueous and we're sending the cell-free DNA to the Birmingham team. So yeah, I know some units, they do a bit of massage to cause a bit of hypotony and so forth, but we actually do a paracentesis. And the issue with the 32 micrograms is they can't, in our hospital, they can't put it in 0.05 milliliters. They could only do it 0.08. So we have to do the paracentesis just to get the volume a little bit reduced in the eye.
Yeah, and in your experience, what's the maximum number of intravitreal injections that you've given?
So that is the maximum number of intravitreal injections I've given. And yeah, so we're watching this space. We really hope, well, the sphere is disintegrating at the moment. But, that's the great thing of having colleagues, and it's nice to see everyone, albeit virtually today, to discuss these things with. It's sort of reassuring for us. And if we're doing anything new in the UK, we often need consensus with our colleagues in Birmingham as well. So we have 2 centres, which actually is great for the families, so they know that other people are looking at it. But it also protects us as a group as well, so that we're all trying to do the same thing.
Yeah, excellent. Thank you. And, looking back at your case of pseudoretinoblastoma, that was very interesting and a very rare presentation. And congratulations for managing it so well.
I just sent it to colleagues so they could do the genetic testing, really.
Yeah. So, many times, we're not able to see the fundus in these many cases of pseudoretinoblastoma, and that's when we really have to rely on imaging. And, so what sort of protocol do you have at your center for, imaging in such cases?
Yeah, so we just do EUA, do RECCAM. If we do have OCT, we're doing research OCT, but unfortunately on that day, the OCT was not available. But I think we mentioned it earlier in the discussion, the panel discussion. OCT is really advantageous, especially for astrocytomas and combined harmatomas, which we're seeing a lot more of these days, rather than good old coats. We just do an FFA and you know what's going on. So I think OCT has makes a massive difference really for those differential diagnoses.
I agree. And what if the fundus is not visible?
Yeah, I mean, there is good work from the Amsterdam about MRI scans and trying to use that in that scenario. Fortunately, I haven't had that problem too often, really. I can't remember the last time where I couldn't see a fundus for a pseudoretinoblastoma scenario, to tell you the truth.
Okay, thank you, Ashwin. It's always a pleasure talking to you, and I could go on and on forever.
Yeah, we could speak an hour, spend an hour just on these 3 cases. So yeah, we better stop now, otherwise Santosh will get annoyed with us.
Absolutely, and we cannot, yeah, we cannot afford that. So thank you very much. Thank you, Santosh.
Thank you, Bhavna. I think Jesse has a point to make. She's raised her hand. Do you have anything to say?
I did. Good morning, you guys.
Hi, Jesse.
Sorry, my throat is a little bit scratchy over here, but I've recorded my lecture, so I win the day not knowing that I was going to have a scratchy throat. Anyways, you all, it's so wonderful to see you. I just wondered, I wanted to make a quick comment that we have a case right now, similarly very resistant. We've done multiple therapy. We've increased the dose. If you had asked me 6 months ago what the highest number of injections I had done, it would be 10, but the average was 6. But this Thursday, I just injected this patient for the 18th time. And not only does she still have cell-free DNA in her aqueous, which we are not using to guide injections, but I can see that it is there. But her seeds are really very minimally responsive to everything that I do. This is her last eye. Her other eye's been enucleated, and it's a 2020 eye. She's 5.
Oh my gosh, yeah.
Had a late recurrence. Yeah, so I
was speaking to Francis about this, Jesse, and the thought was to go to 50 microgram topotecan. Have you gone down that route yet?
No, we have not, but I'm glad to hear it. Francis is coming this week for Lynn, so I had planned to speak to him about it. Yeah.
So
Carol's going to say something,
if
I think.
This series of injections don't work, that's what we're hoping to convince colleagues to do. Everyone's a bit jumpy about it because it's never been given in a human, but you know, it's like you, it's an only eye. We've given all these injections. We have to do something to try and say, and the mother is very keen that we try everything possible.
Of course, same. And I'd like to avoid radiation, and the seeds are pretty diffuse, so she would need external beam. You know, it's not even like I could say, oh, I'm gonna, it's just in this quadrant, it's not, so.
Yeah, I just wanted to make one point. When I see that we're having kind of resistant vitreous seeds and we're giving melphalan and topotecan, I always make sure that we are very prompt with our melphalan injection. We actually have a person stationed at the pharmacy who runs the medication over to Will's for us to inject it, because you only have, you know, a few minutes to get that in and it's inactive. So you might want to check with your pharmacist and make sure they're not sipping coffee while they're mixing
we've put lots of incident forms about that, Carol, and made lots of complaints about that. So they're well, and we're very familiar with that. Yeah, so we do have someone running up from pharmacy to do it. When they had to run across London, it was a bit more difficult, but you know, that was tricky. But from pharmacy, they're doing that now.
Thank you so much. We have the next speaker, Ashwin Malipatna from Sick Kids Toronto, and his discussant would be Raksha Rao from Narayan Netralaya, Bangalore, talking on staging and classification of retinoblastoma. Ashwin, you can begin.
So you muted, sir. Sorry, I was muted. Thank you very much for inviting me, and my talk is on staging and classification of retinoblastoma, whether it's apples and oranges or is it all the same thing. The traditional current staging system that we're all accustomed to is the ABCDE, where A are the smaller tumors, B are those that are more larger or more central, and C are the ones with focal seeds or subretinal fluid, and diffuse are the ones with D are the ones with diffuse seeds, and E are the ones that are eventually unsalvageable or destroyed in some way or considered dangerous. This was the way that we learned staging in 2005 when Dr. Honavar had his the meeting in India. The ISO was held in India, and we were all introduced to this at that time. We were all in the handouts also guided towards enucleation of group EIs. So later on, many years later, when I started to see that some group EIs were being salvaged, I started to question which kind of group E could be salvaged in some way, and started to learn that there may be an entirely different definition of group E from what I was accustomed to at that time. And that came as a bit of a revelation to me, certainly I was not alone in that. And there was a paper published by the group in New York that compared the two versions of A, B, C, D, E. And we know that the Los Angeles version has differences to the ones that were guided by Philadelphia. And the main difference there was the fact that any tumor that's occupying more than 50% of the globe was considered to be a group E, and not so in the Los Angeles group. Does that make a difference? Will that make a difference clinically? We do know that some of the publications in a way try and adopt both methods, although they say that the publication uses ICRB and group EI by definition. We do know that half the definition could be taken from one and components of the other added to that as well. If you look at a retrospective review of intra-arterial chemotherapy, that also mentions the salvage rates according to the classification from A to E, but it doesn't mention the different classification systems that are used in each of these papers. Therefore, some of these, and some of them, of course, not even mentioning which one of those two they've used. And some of them we're presuming based on what they have written in their text. Just anecdotally looking at this in using unilateral eyes that were primarily enucleated, we can see that these different definitions, if you take only 50% as the differentiating factor between an EI and a DI, we can see that the proportions of high-risk pathology that are reported in these studies, all from North America, are different, and maybe that can be explained by the fact that we're accounting size in some systems and not accounting for it in others. So how does all this matter? Does it really matter what we call these things? I just want to break the pace here and go to an anecdote that will maybe elicit how it's important when we call something something that we're not used to being called that. This is very familiar to all of us, and when I was in India, it was being called Hawaii chappals, but in Canada it was being called flip-flops. So I was familiar with both. Then when I went to Australia, I did not, for the beginning bits, know that these were called thongs. So when someone actually told me not to wear thongs to the driving test, it was a bit of a surprise, and I was wondering why I would need that kind of an instruction. So it does matter about what you're thinking about, and when you call something a thing and it's not really what you think it is, then we are talking about apples and oranges, and we're not talking about the same thing over there. To try and solve that, we thought of maybe rejigging a system at some point that could be used by everyone. And this was the group of people who've gone ahead and brought some consensus, and through the AJCC and through the work of Paul Finger and the rest of us in that team, we brought forward maybe an evidence-based classification, evidence-based staging system by which we can discuss different types of retinoblastomas that present to us. So the essential questions that we had were, can we generate an updated definition of what advanced intraocular disease would mean, and which group D or E is really associated with high-risk pathology, which eyes fail salvage therapy, and should we really enucleate some of these up front? We did not consider older systems such as the Reese-Ellsworth classification, which had the size of tumor described in disc diameters, and whether there were single or multiple tumors, and whether the entire anterior extent of the tumor was not considered in this system as individual risk factors. So right now the AJCC is at its 8th edition, and currently is the only evidence-based staging system for retinoblastoma. We looked at peer-reviewed literature. We looked at a survey of about 2,800 eyes from about 2,000 children with retinoblastoma from all around the world, and we came across deliberations and consensus which were not easy in any way. The principles itself of the AJCC system is that it has to conform to anatomical stages, therefore sometimes referred to as a surgical classification. And each stage would represent a progression in the anatomical extent of the disease. And there were quite strict instructions on how many categories you can have, and the diagnostic imaging techniques that you can propose, and those sorts of things to actually come to the final stage of each child at diagnosis. So very broadly, we're looking at a tumor in a very stage-wise progression right now, which is an intraretinal tumor goes on to fill in the eyes with either a detachment or vitreous seeds, and goes on to then progress further into CT3 eyes, which are advanced intraocular, which are those that we would consider E eyes mostly, and then from there spread to the extraocular sites. So that progression was maintained, and there are subcategories, of course, that some people do find confusing, but it does have a method, and it's easy to learn when you've gone through this system multiple times over many weeks. So just to break it down a little bit, T0 is when an eye has, or this is only the clinical staging system, where T0 is an eye which has no tumor. T1A is a small tumor or something that's, and if a small tumor is closer to a disc, it's T1B. And if it's even a larger tumor, then it could be a T1B or even closer to the macula. T2A is where you start to have retinal detachment, an exudative detachment. And T2B are the ones that you start to have either subretinal or vitreous seeds. And T3s are those that we would consider the eye unsalvageable in some way, such as with hemorrhages or anterior segment involvement, or a cataract or buphthalmos or glaucoma or any of the others. And we actually broke it down with A to E, with what we thought at that time was the ones that correlate with least with high-risk pathology on top, and the one that correlate most with high-risk pathology below. So there is some sort of an hierarchy there. And I must specify that tumor invasion is required for T3B. Previous to this, it was only considered that tumor touching a lens would still be an anterior segment invasion, but we don't. We tried to make that distinction clear by saying that there should be some evidence of invasion, not only contact. There is T4A, where you have radiological evidence that the tumor might have left the eyeball, and T4B, where you have overt extraocular involvement, where the tumor has maybe even clinically has evidence of having left the eyeball. With the TNM system, we do have nodes where N1 would be the involvement of lymph nodes and M1 would be the involvement of distant metastatic sites, M1A and B distinguishing CNS and distant sites. We do use prefixes as well. C is for clinical, P is for pathological, and the prefix of Y would tell you that treatment was provided prior to this staging when you're trying to restage a child. And with the pathological classification, we tried to maintain a similar stage-wise approach. It was a little bit harder, where PT1 was tumor without local invasion, PT2 was only local invasion, PT3 was significant local invasion, and PT4 would be extraocular. And of course, we also had the pathological proof of metastasis, which was A and B, with the hematogenous and central nervous system being involved. The pathological staging system, again, when it's described, is PT1 is when it's in the eye, PT2 is when there's focal involvement, or PT2B could be the ones with involvement of Schlemm's canal, and PT3A is where you have choroidal involvement, which is massive, and PT3B is retrolaminar choroidal involvement. PT4 is where the tumors left the eye. Okay, thank you. I'll quickly run through this. So what evidence do we have now? Thanks to Dr. Tomar and his statistical prowess, we've rejigged the evidence and recently published on the patient survival in each of these stages, which is listed here, as you can see, and it does go in a hierarchical manner, with the least survival being those with obviously extraocular disease, and group E eyes are what we used to call the CT3s over here. If you look at treatment failure as well, you can see the similar progression, where secondary enucleation is more common in those with CT3 eyes, and up to 56% of them were enucleated secondarily, or maybe even went on to get radiation between January 2001 and December 2013. And a similar progression with high-risk pathology in primary enucleation, where you have the highest risk in these eyes by the definition of CT3 that have a high-risk pathology there. I wanted to go through some case examples, but I think in the interest of time, I will run to the summary about why we should really bother. This is the only stage-wise progression system that we know of right now, which follows the natural history of the disease, and it better defines an eye that might be at risk to preserve. Therefore, CT3 we think is potentially unsafe. This also combines the IRC and ICRB in some way, and the staging of the IRS as well, which is Dr. Shantada's staging system. And this moves away from the familiar but inconsistent group D or group E that we all talk about. And it's one system that's useful to ophthalmology, oncology, radiology, pathology, and genetics. And there are more reasons, such as the introduction of H1, which is very useful and better defining what we would consider high risk, because it's not binary anymore, and there's actually a spectrum to this according to the staging system. So for anyone who's interested, there's a handout, and they can download the presentation as well. With this, I thank everyone, and I would like to stop for questions. Thank you.
Thank you so much, Ashwin. As usual, you covered it very exhaustively and very nice inputs. Raksha is the discussant. She's from Narayan Netralaya Bank.
Yeah, thank you, Dr. Ashwin, for a very insightful talk. Examples that I've included in this presentation of mine, and I would like to discuss with you how would we incorporate that in the AGCC 8 system. So this particular case is that of a retinoblastoma group D, where the vitreous seed type is the cloud type, and it has taken a very long treatment process and a very long time to achieve a large amount of regression as you see in the second picture here. So post IVC 6 cycles, the intravitreal topotecan and 7 injections, and a combination therapy of topo and melphalan intravitreal injections of 5, and still ongoing focal therapy, there is still some tumor that is remaining. As opposed to a retinoblastoma group D, where the vitreous seeds are mostly spherical type and the main retinal tumor was almost the same size as the previous case. A large amount of regression was obtained just with intravenous chemotherapy of 6 cycles and intravitreal topotecan of just 2 injections. And you see that most of the vitreous seeds have been calcified. So based on this particular paper as well from the Abrahamson group et al., in their table as well, they mentioned that it is the cloud type of vitreous seeds which takes longer time to regress and which requires a higher median number of injections. As also in another table, they have described that the ocular survival rate of eyes with spheres is less than those as compared to cloud and dust type of vitreous seeds. So there's definitely a need for redefining group D on the basis of type of vitreous seeds. So how would you say that we would incorporate this in AJCC 8?
That's a good question. I think Ankit has published a paper on vitreous seeds and how that impacts ocular survival as well. I think our challenge at that time was that we had retrospective data up to 2013, and intravitreal chemotherapy was not quite heavily featured in those cases that came up there. So the group consensus that we had was that we wanted to simplify the seeding in some way, that we wanted to take away what we'd consider focal seeds and diffuse seeds, because we had at that time felt that with intravitreal chemotherapy at that point, which was already introduced, we thought that things would be very different from then forward. Therefore, taking away what we would consider focal to diffuse seeding. And maybe if there was evidence, yes, bring it back in some way or bring it differently. We did discuss with Francis Mounier at the same time, who's also an author in that chapter, about the different types of seeding, which is cloud, spheres, and dust, and whether we should incorporate that or not. The challenge there, of course, was how we would do it within the AJCC structure. Therefore, if we have seeds as a category that's not differentiating subretinal or vitreous seeds, then can you introduce a subcategory? So then it would become a 2B1 or a 2B2, and we were hesitant to make it more complicated in that way. In fact, we were even hesitant to separate subretinal seeds from vitreous seeds as well, although they have an anatomical distinction in some way for us during presentation. So yes, you can make further correlations from here. I would think we'd still want to keep the larger system less complicated, or as simple as possible in terms of representing globe salvage and representing survival. Because really for the AJCC, the primary objective was survival of the patient. And then obviously for us as ophthalmologists, eye survival is very, very important as well. So we were trying to incorporate both, but not get too complicated. That was the attempt. And yes, there is certainly going to be evidence that comes up in the future. We want to try and make sure that, if we stay as an anatomical progression in the system, then I do think that the subgroups might change a little bit, but the larger groups, which is T1, T2, T3, and T4, shouldn't change for the future.
That is true. So you have mentioned my next example also, the group D with vitreous seeds versus group D with subretinal seeds. We have all noted that the exudative type of group D responds much better than an endophytic kind of a group D to both IVC and IAC. So probably this also will be included in AJCC, the smaller subdivisions.
I mean, we're not proposing anything within the structure of AJCC. I'm not sure if we're allowed to, and if I'm given the opportunity to do this over again the next time, then we'd see if the rules have changed a little bit. But for the time that we did this, it wasn't really we couldn't accommodate that detail in it without losing, let's just say, the usability of the entire thing.
Sure. So again, group E, there are different high risk factors, a very diverse group which has preseptal cellulitis thisis, which has obviously almost zero scope for ocular survival. However, like our recently published article on NVG, we noticed that certain eyes are definitely salvageable. So I know you have made a subdivision of A to E in the stage 4 of AJCC.
Stage 3.
Shouldn't this have stage 3? Sorry, yeah. So shouldn't this have been a little on the higher side NVG, since we know that some of the, and even Dr. Carol Shees also has published a paper where they have mentioned about an NVG case which was salvaged.
Yeah. So at the point at which we'd actually put that out, there was not that kind of a large series that we could rely on with that kind of evidence at that time. Any evidence that comes up, of course, will be considered for future editions. We would like to stay evidence-based with modifications as well. But that being said, if you look at it, we broke it down into subcategories instead of just calling it a group E, because before all of this would be lumped into a group EI, but we actually broke it down into subcategories because of this. We wanted people to actually go out and investigate the differences between these small groups. Absolutely. And then glaucoma would come under
3C, I think.
C is what I think, yes. Yeah. So if it's C, then you can tell us that C is in some way vastly different. And if it's peer reviewed and accepted by the panel, then I would hope that it gets included in future editions as a difference. Yes.
Okay, so this is the last set of slides. So this is the retinoblastoma group C, which has wonderfully responded to intravenous chemotherapy, and a very bad group D, which has responded wonderfully to IAC. So since we know that the international classification of retinoblastoma was invented at the time chemotherapy and post-chemotherapy, the response to chemotherapy, so should there be a definite a new staging system in the era of intravitreal and intra-arterial chemotherapy?
So that's a good point again. I think that's why we've tried to stick to anatomical definitions. That's the reason why we didn't want to go into too much with the larger groups. With the subgroups, yes, you can go a little bit into which one might be better, which one might respond better in some way. But I think with the larger groups, it was important to stick to the natural history of the disease itself. And I think that's the strength in the AJCC staging system, is that it represents a stage-by-stage progression of disease. I think we managed that with the clinical staging, but it may be work in progress with the pathological staging system.
Dr. Santosh, last question, if I may permitted to ask. Dr. Ashwin, it was a wonderful presentation. Is there any analysis done on the differentiated part of the retinoblastoma, well differentiated versus poorly differentiated in terms of the outcome?
I do remember that coming up as a discussion point. The grade of histopathology is in the chapter. And the grade is according to differentiation as well, but I think we decided to keep that as it was with the older edition, if I'm not mistaken. I can't remember off the top of my head, but I can send you an email about what we discussed for the chapter. I've kept all the minutes for the chapter discussions,
maybe that if you have some retrospective data, then you probably include it in the AJCC classification.
I think it's already there, but as a grade of histopathology, not into the staging system itself.
Thank you. Thank you.
Dr. Santosh, can I ask
Thank you,
a
Dr.
question? Can I? Yeah.
Yeah,
Hi,
sorry.
Ashwin. Yeah, I mean, congratulations for all the hard work in putting, up the AJCC classification. But we're
Thanks,
also
but I can't take that alone. I have to take it with the entire team.
Absolutely. So actually, we are also thankful to Dr. Carol Shields and Lynn Murphy for the initiation of bringing in an easier classification system, of course. We all know that things evolve over a time, treatment evolve over a time, and well, there are many changes. And I think there is certain probable evolution that will happen in AJCC also. And Raksha has pointed out so well, the precise points on it. I have one more, question for you, Ashwin. So when we are talking about the T4A and T4B, so T4A is about the optic nerve extension. And as, retinoblastoma specialists, we all know that anything which reaches the optic nerve is more serious than an orbital extension, which could be even an anterior, a mid or a posterior, extraocular extension of the tumor. So
Sorry,
optic nerve extension.
Can I confirm whether you're talking about pathology or?
No. I'm talking about the clinical. So in clinical, the T4A is radiological confirmation of optic nerve involvement. And T4B is extraocular extension, which is overt.
Maybe the description of it is radiological evidence of extraocular disease. It doesn't have to be it could even be extrascleral without having signs of overt orbital disease. One is clinical and the other is radiological. That's all. It's not specific to the optic nerve alone, but you're right in that a lot of the radiological reports get reported as optic nerve more than a breach of sclera.
Correct. So I just feel is that, we should consider the optic nerve involvement a little bit more advanced than an orbital extension of the retinoblastoma in T4. Well, we can take opinion from Dr. Carol also on this.
Thank you, Dr. Ferouz. We base, with all due respect to the AJCC, we base a lot of our indications for, systemic therapies on what Ralph Eagle, who's sitting here on this seminar, reads out. And pathology is really important to us. We tend to use the International Classification of RB clinical and then histopathology for our indication for systemic chemotherapy. But I agree with Dr. Ferouz. I think we're just in evolution. We're going to eventually probably use AJCC in a way that it is very predictive.
Thank you. Thank you, Ashwin. Thank you, Raksha, for your wonderful discussion.
Thank
you. Ferouz, do we have any questions at this stage?
Yeah, we have a very interesting question from the audience for Dr. Gombos. The question is, should we screen a newborn who has a strong family history, but is a product of IVF and had pre-implantation genetic testing?
That's a very specific question. And Dan has left, actually. He had a parallel engagement. If anyone else can take this.
Any faculty can take.
Helen is here. Helen is on the genetic side as well, but I would, I don't know if she's muted or.
Helen, do you want to speak up?
Sure. Well, I guess if the family has gone through IVF and had pre-implantation genetic diagnosis to only transfer the embryos that have not carried the causative mutation, there's no reason to do the screening. You could see the child to make the clinicians can actually talk about what they do in terms of the family's comfort. I'm not sure if you do another test after the baby is born, a genetic test just to confirm, but theoretically speaking, the pre-implantation genetic diagnosis should be enough to rule out retinoblastoma in that child.
Thank you.
I
I
would
would like
agree.
to make it.
Sorry,
I would
go
like
ahead.
to make one quick comment. When something like this comes up, at least in our hands, we tend to be very cautious, and we do at least 2 examinations on the kid. I don't take them to anesthesia. I just do it in the office because I just want to be sure clinically that the genetics were correct. I will tell you a story of an ophthalmologist who was told his child had Down syndrome. And at birth, the child did not have Down syndrome. And there was another child who was sampled the same day the parents were told the child didn't have Down syndrome. There was a mix up in specimens. I will never forget this story because it happened to a friend of mine. He was preparing for a child with Down syndrome, but his child didn't have it. There was a mix up in the lab. This is why I always do an examination at least twice on these kids. Even if the pre-implantation genetic diagnosis is negative, I just want to prove it to the parents.
Dr. Santosh?
I have nothing to add.
I think the strong family history is the bit, and really, if the parents are concerned in some way, you might want to look a few more times. But really, I don't think it's if you've got genetic confirmation that you don't have a risk in that child, then we might not consider an anesthesia at all. We might only do this with clinic exams. And with a smaller child, it's easier to do this in clinic. Even with an awake ret cam in the smallest of children, as soon as they're born a few weeks old, a ret cam while they're wrapped up and with a soother in their mouth is easy enough. If you don't think you can get, let's say, a more relaxed, indirect ophthalmology look into the eye.
That's it. Any more questions? We'll move on then.
No, yeah, just the relevant one, Dr. Santosh. Yeah,
Sure.
okay.
So the next speaker is Dr. Carol Shields, and she's going to speak to us on intra-arterial chemotherapy. Where do we stand in 2022? Discussant is Dr. Mahesh Shanmugam from Shankaraya Hospital, Bangalore.
Can you see my slides?
Yes.
Okay. So I have no financial disclosures relative to this topic. I'd like to talk to you on progress with intra-arterial chemotherapy, the Philadelphia experience. So it's all about kids and life and vision. There are different ways to manage retinoblastoma, as all of us know, including enucleation and methods of chemotherapy: intravenous, intra-arterial, intravitreal, intraaqueous, and even plaque radiotherapy. But most of us around the world now use chemotherapy. The classification of retinoblastoma that we use in Philadelphia is the international classification, groups A, B, C, D, and E, where A is small tumors, 3 millimeters or less. B is bigger tumors greater than 3 millimeters, or those in the macula or with subretinal fluid. C with contained or localized seeds. D with diffuse seeds. And E extensive, greater than 50% of the globe, with neovascularization of the iris and possible opaque media. This classification was established in 2003 with communication of Lynn Murphy and me through emails and over the telephone, and then established in Paris. However, since then, other classifications have come out. So we still use this one that we decided on. What about intra-arterial chemotherapy? We tend to use this as a primary therapy for children with unilateral retinoblastoma. We give it through the femoral artery in most cases, but for children over the age of 5 or 6 years, we're now giving it through the radial artery, which is a little bit safer. So years ago, Lauren Dalvin, when she was a fellow with us, published our early experience on primary intra-arterial chemotherapy in the intravitreal chemotherapy era. And we found that IAC is effective for groups B, C, D, and even some E eyes. And intravitreal chemotherapy is important, especially to achieve globe salvage for groups D and E. So that's when we tend to use the intravitreal. We did a head-to-head comparison and published in the Asia Pacific Journal of Ophthalmology of intravenous versus intra-arterial chemotherapy for unilateral retinoblastoma. In this analysis, we found for unilateral RB, IAC provided significantly superior globe salvage compared to intravenous chemotherapy for group D eyes. And in addition, IAC provided superior control of the solid tumor, the subretinal seeds, and the vitreous seeds. So if we look at this graph, groups A, B, C, D, E, we see the yellow columns represent intravenous chemotherapy with pretty good results for B, C, and intermediate result for group D in globe salvage. But when you compare that to IAC for unilateral retinoblastoma, at least in that publication, we had 100% control for B and C and about 90% control for group D, and that was significantly better than intravenous chemotherapy. And if we look at the components of tumor, looking at solid tumor, subretinal seeds, and vitreous seeds, you can see intravenous chemotherapy does offer some control for subretinal and vitreous seeds, but it's much better with intra-arterial chemotherapy. 75 to 90% of vitreous and or subretinal seeds are controlled just with the intra-arterial chemotherapy alone, without even injecting intravitreous chemotherapy. And of course, solid tumor is significantly better controlled with IAC. You can see same with the subretinal seeds, significantly better, and same with the vitreous seeds. So when you compare unilateral retinoblastoma, who does better, IAC or IVC? We think IAC wins. It's much more robust, and this is why we choose IAC for unilateral retinoblastoma. And this is important because most unilateral retinoblastoma is advanced. It's group D or E in 75% of cases. So let's look at a few cases here. This is a child we saw who had a macular retinoblastoma, exophytic, group D, with subretinal fluid nasally. And this child received 2 doses of IAC melphalan with beautiful regression, leaving the scar in the macula, but all disease under control. And here's another endophytic retinoblastoma, mostly located nasally. And when you look at the fundus retcam photo, you can't even see the retina. There was a little bit of normal retina superotemporally. After 3 doses of IAC, 6 doses of intravitreal chemotherapy, we now have a macula, a normal nerve, a regressed tumor, and the OCT is intact. This eye saw 20/40. This kid is maybe 8-9 years follow-up and has had no recurrence with following intra-arterial chemotherapy. Now, Dr. Ferouz, who's on this seminar, along with Dr. Santosh and our team, published an article in the Indian Journal of Ophthalmology, where we indicated IAC is a total paradigm change in how we manage retinoblastoma. And in this article, Dr. Ferouz indicated all the different ways that we can deliver IAC, using it as a primary treatment or a secondary treatment. We do use it as a secondary treatment after failure of intravenous chemotherapy, and even as a tertiary treatment. If it fails again, we'll go back to IAC. We don't use it for tandem treatment in Philadelphia. We do what's called staggered, not tandem IAC. We stagger IAC right eye, then 20 days later, we'll do IAC left eye, because we don't want to have any catastrophic events doing tandem IAC. And yes, we do bridge IAC, where we give intravenous in super young kids and then go on to IAC. Here are some special considerations with IAC. We'll begin with minimal exposure. How little can we get away with? Well, there are some kids that we only have given 2 doses, melphalan intermediate 5 milligram dose, and we only give it for 2 cycles. On the top, ABC was one case, and on the bottom, DEF was the second case that got by with just 2 doses, and we have many more. How about the youngest and the oldest? We tend to limit this by the patient's weight, and we generally treat 3 months or older with IAC, but there have been a few 2-month-old children, infants, that we've treated with IAC. This is the little guy who we treated from Chicago, unilateral retinoblastoma. He responded to 2 cycles of 5 milligrams of melphalan and required nothing else thereafter. And the oldest patient that we treated was a 32-year-old man, came from Texas. He's the oldest one that we've treated, but we've treated several 20-year-olds now with IAC. He had recurrence of this tumor in his left eye, and IAC shrunk it down nicely. I have to admit, he did require intravitreal chemotherapy also. Here's a 13-year-old girl. She had endophytic retinoblastoma seen clinically and on the ultrasound. She was the first that we were able to do transradial access. This is safer because if you get hemorrhage, it's not going to go in the retroperitoneal space. And that's what the interventional neuroradiologists worry about. In this case, we went through her radial artery and gave IAC with good results. And we tend to use that for older kids where the radial artery is a little bit larger. And then we've published our publication of 14 years experience with IAC for retinoblastoma in the Journal of the American Association of Pediatric Ophthalmology and Strabismus last year, where we looked at 341 consecutive eyes, 1292 infusions, and looking at a comparative analysis based on patient age, race, and sex. Who does better? Here's an example of a massive group E that we were able to save the eye with IAC. This child is 3 to 4 years out with complete control. So in that analysis, we did Kaplan-Meier graphs looking at globe salvage. So if you look at this graph at 5 years follow-up, group B, we have 100% globe salvage. Of course, we don't do IAC for group A. For group C, we have 80% salvage, group D, 78% salvage, and group E, note that this is selective group E. We don't choose every group E for treatment. We're able to save over half the eyes. And when we look at primary IAC for retinoblastoma, our 5-year overall globe salvage was 76%, with a mean of 3 infusions, but we go up to 8 infusions. And if a child doesn't respond and we've given 8 infusions, we tend to move on to likely enucleation. Complications are pretty low, only 1% per infusion. Now, if we look at the outcomes based on patient age, less than 1 year versus greater than 1 year, you're going to see control of solid tumor is a little bit better in those under 1 year of age. And control of subretinal seeds doesn't matter based on age, but control of vitreous seeds, a tiny bit better in the younger cohort under 1 year of age, but control of globe salvage, significantly better in young children under 12 months of age compared to older children. And comparison by race and sex, no difference. So what about complications of IAC? When we first started, we had really bad complications. It's a difficult technique and there is a steep learning curve. But as time went on, our complication rate decreased. So if we look at a comparison of primary versus secondary IAC, there was no difference in complications of retinal ischemia, choroidal ischemia, neovascularization, or any of the complications based on primary versus secondary. And looking at age, no difference, race, no difference, and sex, no difference in complications. So in conclusion, for that large database, our results suggest that IAC provides substantial tumor control for advanced and or recurrent with a high rate of globe salvage and few complications. So in summary, it works for retinoblastoma. We tend to prefer to use it for unilateral RB or for eyes that fail intravenous chemotherapy. Thank you for allowing me to give this talk from our retinoblastoma team in Philadelphia.
Thank you so much, Dr. Shields. Mahesh Shanmugam will discuss.
Thank you, Dr. Shields. It's, as usual, a great pleasure listening to you and learning from you. Can I share my screen?
Yeah, please.
Yeah, sure. Thank you once again, Dr. Shields, for a wonderful lecture and for continuing to inspire and educate us. So Dr. Shields has showed us that like IAC works, and it's probably the preferred treatment in the developed world as far as the unilateral retinoblastoma is concerned. So what about us? Have we, all of us in India would like to switch over to IAC if it is possible. So let's look at the Indian context as to where we stand. And I had written a commentary on Dr. Shields' article in 2019. So the concerns we raised were this. So the intravenous chemotherapy, as far as India is concerned, we can do it for free. We can do it to patients who cannot afford it. We can do intravenous chemotherapy for free. Otherwise, it used to cost around 5,000 per cycle versus the intra-arterial chemotherapy, which costs around 50,000 to 100,000 per cycle. And the stumbling blocks which were there and which I thought could be overcome were by indigenous development of the catheter, because catheter is one of the most expensive parts as far as IAC is concerned in India, and increasing the number of centers performing the treatment. In 2019, most of the IAC was being done in corporate hospitals versus the non-profit organizations or government hospitals. I thought if in case non-profit organizations and government hospitals walk into the act, then the cost of IAC may come down. And if there was any governmental intervention in rationalizing the cost. 3 years later, where are we today? So I just did a small survey of 5 or 6 centers across the country which treat the largest number of retinoblastoma patients, including us, and we have found that currently only around 10% of the patients in India are being treated with IAC. So the range is between 5 to 30%, and around 90% of the patients we still treat with intravenous chemotherapy. So why is it? Again, cost is a consideration. So the cost has come down. So in a government hospital, we can do IAC for around 25,000 per cycle, but most often the cost is around 100,000 to 150,000 in contrast to IVC, which is around 5,000 to 10,000. So if you look at the total cost, 3 cycles of IAC would cost about 300,000. In contrast, 6 cycles of intravenous chemotherapy will cost us 30,000. So IVC is nearly 10 times less expensive as compared to IAC. So that brings us to the important question of ability to treat patients who are in the lower socioeconomic group or who cannot afford their treatment. So can we offer IAC as a free treatment to these patients in the lower socioeconomic group who cannot afford them? Yes, but this is on a case-to-case basis. So the treating organization, treating hospital, if it's a non-governmental hospital, then it absorbs the cost. Otherwise, we reach out to a funding agency which is able to afford, which is able to give us the treatment cost. And in contrast, the intravenous chemotherapy is being done in most of the government hospitals and non-governmental hospitals as well. So it is possible to treat them for free, or we are able to absorb the cost much easier. And again, the government scheme, what is called the Ayushman Bharat insurance scheme, which covers the large population of this lower socioeconomic group, the intravenous chemotherapy is covered under that. It's not specific for retinoblastoma. Any chemotherapy is covered. And so intravenous chemotherapy is covered under the insurance scheme, which covers the lower socioeconomic group, which does not happen in the intra-arterial chemotherapy. So we have made some progress in the last 3 years. So there has been an indigenous development of the catheter, but unfortunately, it's hardly much different from the cost of an imported catheter. And there has been an increase in the number of institutions performing intra-arterial chemotherapy. Particularly in Bangalore, we have 2 government institutions which do perform intra-arterial chemotherapy, similar in Delhi as well as in Chandigarh, I presume. And there are non-governmental organizations which do perform intra-arterial chemotherapy in contrast to only corporates earlier. So corporates, we had no control over the costs, but then now there is some control over the costs, and people can afford IAC a little bit better than what it was 3 years back. So can the government rationalize costs? Yes, as I mentioned, IVC is covered under the insurance scheme. IAC may be in the future, but then to summarize, IAC is preferred treatment in unilateral RB as shown very elegantly by Dr. Carol Shields. Though in India, we would like to adopt to IAC, but then cost constraints still remain a stumbling block. We have made some progress in the last few years. We can try lobbying for including IAC in Ayushman Bharat or the insurance scheme, but then RB is a very minuscule health issue in India compared to all other larger issues. So I'm not too sure if you'll be able to lobby adequately for the government to include a particularly expensive treatment for a very small percentage of the population. Future, yes, there will be a slow increase in IAC penetration, but I don't know if we'll be able to do as frequently as what it is in the developed world. IVC is still a great treatment, but probably a little poorer person. And thank you very much. And I thank the other collaborators who did give me their data very much easily for me to put up this presentation. And thank you very much. Thanks once again, Dr. Shields.
Yeah, thank you, Dr. Shanmugam. That's really multiple important points that you bring up. We've had some very impressive forward strides in the management of retinoblastoma during my career. Number one, intravenous chemotherapy. Number two, intra-arterial chemotherapy. And number three, intravitreous chemotherapy. But of these three major developments, I agree with you. Intravenous chemotherapy was the biggest step that we took and is still the best, I think, most successful development in the management of retinoblastoma, just because it can be used in every country. So my hope would be that, the cost for intra-arterial chemotherapy will come down and be more affordable, especially in your country. I know in the country of Chile, they wrote an article in one of the American journals about the cost of IAC in Chile, in South America, and they were able to get the cost down to $5,000 US, which is, amazing, just through using certain techniques. And that was written by Diego Asandon. And, I have hope that it will be more affordable in the future. But I'll be the first to agree with you that intravenous chemotherapy is still a great treatment, and especially for bilateral cases. Yeah. Mm-hmm. Any other questions?
Any questions, comments, quickly? Any audience questions? Okay, so I suppose that seals it. We'll move on. Dr. Munir is yet to join. I'll call him. In the meanwhile, I think we can take the next talk, that is by Dr. Jeseveri on liquid biopsy. She has done seminal work on this aspect, and her discussant would be Dr. Swati Kalki from L.V. Prasad Eye Institute, Hyderabad. Jesse, are you ready? You have a video to play. You're muted.
You guys have the video, right?
Who did you send that to us?
Earlier in the week, I sent it to you and Swati. Swati, do you have it? I can pull it up. I don't know how to play the video here myself, though, honestly, but I can try.
Swati, you're muted.
Yeah, I can pull out the video. Just give me a minute, Dr. Honavar. Yeah, so I have it on my screen. I'm just going to share it.
You've got it? Okay, I have it too, but go ahead, Swati. Thank you.
Yeah.
Hello, I'm Jess Berry from Children's Hospital Los Angeles and the University of Southern California. I'd like to thank the organizers for inviting me today to discuss liquid biopsy applications for retinoblastoma, from diagnosis to prognosis of ocular salvage. These are my financial disclosures. As we all know, unlike most tumors, retinoblastoma is not directly biopsied, and this is due to concern for extraocular tumor seeding. However, While we're still pretty good at looking into the eye and diagnosing this disease, a lack of biopsy does have some real-world clinical applications. First, for the management of this cancer, we have a complete lack of eye-specific diagnostic and prognostic molecular biomarkers. Much of this is subjective and relies on the clinicians looking directly in the eye. We have a lack of any personalized treatment plans because we are not using these molecular biomarkers to inform our care of this cancer. And finally, we have almost no understanding of in vivo tumorigenesis, by which I mean how these tumors change on a molecular level under therapeutic pressure. This changed when we took the new opportunity afforded to us by a safety-enhanced mechanism for the treatment of seeding in retinoblastoma. As part of intravitreal injections, aqueous humor was taken, and multiple studies have now shown that there are no documented cases of extraocular spread. And we aimed to investigate this new opportunity to discover whether or not the aqueous humor could be used as a surrogate to tumor biopsy, or rather a liquid biopsy for retinoblastoma. And in 2017, we published our first proof of principle paper demonstrating that the aqueous was a valid and effective biosource for liquid biopsy. So what is liquid biopsy? Of course, it is a biofluid. It can be CSF, saliva, urine. Frequently, it is blood, or of course, in this case, aqueous humor. That's a mix of cellular and non-cellular components that are derived from the tumor, but not due to a direct tumor biopsy. And while a tumor biopsy can give a snapshot in time of what's going on at the molecular and cellular level, a liquid biopsy really gives a more comprehensive evaluation, given what we know about heterogeneity in tumors and multiple tumor clones. And this, of course, is important for retinoblastoma. And finally, another advantage of liquid biopsy is that it is repeatable during treatment course longitudinally, so you can see the ways in which this tumor changes over time. There are two main mechanisms for detecting tumor DNA, and I think it's important to just briefly go over them. The first is whole genome sequencing, where you sequence small little pieces along the genome in order to identify whether there are areas of too many or too few chromosomes. It's known that tumors co-opt this chromosomal machinery in order to grow, and this is also well established with retinoblastoma. And so these chromosomal alterations prove that the DNA is tumor-derived. Another mechanism is to directly, deeply target the RB1 gene, looking for any mutations, which would obviously be suggestive that that DNA is also tumor-derived. These are two separate mechanisms, kind of in the same way that we do an examination under anesthesia to look into the eye, as well as neuroimaging to get an idea about optic nerve invasion or CNS disease. Different mechanisms to find tumor DNA, just like different mechanisms to diagnose retinoblastoma. Our research so far has allowed us to answer some really important questions, and I'd like to go over them with you now. The first, of course, is the big one. Is there tumor DNA in the aqueous? We and others have very clearly shown that the answer to this is yes. At this point, we have multiple years of data and over 200 samples. We've been able to standardize our methods for collection, handling, storage, and processing. Greater than 80% of the DNA in the aqueous humor appears to be tumor-derived. And in fact, in our hands at our laboratory, 95% of samples have DNA, 80% of which we've shown to be proven tumor DNA. However, we actually think that that number is probably higher. And as patients are treated, there's less DNA in the sample, but with deep sequencing, you could still identify RB1 tumor DNA. And in fact, we also looked at diagnostic samples, or samples taken at the time of diagnosis under research protocol from eyes that are then treated with intent to salvage. And in these patients, 100% of samples had proven tumor DNA, either by the detection of RB1 mutant DNA or these chromosomal alterations, or both. Can the aqueous humor play a role in diagnosis? The answer here is also yes. As we've discussed, our lab and others have shown that with this DNA, there's a high enough concentration in the aqueous humor to reliably and accurately identify the specific RB1 mutation or mutations, if there are two, as well as to identify loss of heterozygosity with high fidelity in these samples. Our lab has also shown that you can do that, as well as the genomic alterations from a single 100 microliter sample. This diagnostic biomarker then leads to lots of other clinical questions we could consider, like what do you do when you lose the view, the rare but persistent diagnostic dilemma, and can we use this to direct need for further adjuvant therapy, like when to start or stop intravitreal injections? Can the aqueous humor liquid biopsy play a role in prognosis for saving the eye? This is most exciting to me as a clinician who takes care of these patients, and so far our research suggests the answer is yes. This really comes to me from my clinical work, and so I think many of us have had the experience of two patients who look exactly alike, are treated more or less with the same regimen because we don't personalize it, and one patient will do very well, the eye will respond beautifully and be saved, while the other will have persistent or recurrent disease in the eye until finally they succumb and require secondary enucleation. So can we use the aqueous humor and the ability to detect tumor-derived biomarkers to predict this better? And so we directly assessed that in two papers, the most recent published in 2020 in Molecular Cancer Research, looking at 50 eyes with over 100 aqueous humor samples and matched tumor samples. And we were able to compare two groups, those that were saved and those that were enucleated. This had not been done previously outside of the aqueous humor research because before you only had tumor DNA from enucleated eyes. But by this novel ability to compare these groups, we were able to identify very clearly here the difference in gain of 6p, so chromosome 6p there, which was not only more commonly found in the eyes that failed treatment and required enucleation, but the amplitude or the number of copies of 6p was higher. And so if we look at what we all do right now, which is clinical prognostication, of course, our group D in green and group E in orange here eyes do worse. In our hands, our salvage rates were about 62 and 33%. But if instead of clinically prognosticating, we use this molecular biomarker and prognosticate by the gain of 6p, only 9% of eyes that had 6p gain in the aqueous humor were able to be saved. And the risk of treatment failure requiring enucleation was 10 times increased in those eyes. Can the aqueous humor play a role in monitoring therapeutic response within the eye? Again, the answer is yes. We've been able to show by looking at tumor fraction, or the percentage of tumor-derived DNA in the aqueous humor, that eyes that have a drop in tumor fraction show very nice tumor response to therapy and are salvaged. Those that do not have a concomitant decrease in tumor fraction tend to be enucleated. And most exciting to me, those that drop and then raise, so have an increase in tumor fraction, that portends an intraocular recurrence of this cancer before the clinician was able to notice a change, as you can see in this case here, from 5 to 6. Does blood play a role as liquid biopsy? The answer is yes. There's been very exciting research around the world, and some of the most exciting has come out of Sloan Kettering, looking at the use of blood. In this case, whole genome sequencing is not done, but rather this targeted sequencing of RB1 mutant DNA, which you can do down to very, very low tumor fractions. The biggest question to me that remains unanswered in the setting of blood is, what does a negative blood test mean? Published studies to date have shown that at diagnosis, about 50% of eyes do not have any detectable RB1 mutant DNA in the blood, and during therapy, 60% or more of eyes don't have that. So we as a community will have to decide, how do you apply a negative blood test in these settings? Can you just use the blood? In my opinion, the answer is no. We evaluated aqueous humor and blood side by side for the ability to identify these chromosomal alterations using whole genome sequencing and found that only the aqueous reliably had a high enough tumor fraction for this. We didn't say that you couldn't find circulating tumor DNA in the blood, but rather that the aqueous humor was superior because of its higher tumor fraction. Not only was it superior due to higher tumor fraction, but remember, 40% of patients with retinoblastoma have both eyes affected. Therefore, an organ-specific or eye-specific liquid biopsy is important. This is illustrated here in a patient with bilateral disease, group D in the right, group B in the left. That gain of 6P is here in the right eye, and you can see that there's differing biomarkers and chromosomal profiles between the eye, even though, of course, this patient has the same predisposing RB1 mutation. None of the chromosomal alterations were found in the blood due to the lower tumor fraction there compared to the aqueous. Finally, are there other eye-specific biomarkers in the aqueous humor? The answer is yes. I'm not going to get into the details of this, but we found extracellular vesicles, microRNA, proteins, and a whole plethora of very interesting research venues that show that the aqueous humor may be able to inform our care in a really personalized and predictive way for the treatment of retinoblastoma. For those of you that are interested, I think there was a really nice review on analysis of cell-free DNA for retinoblastoma in both the aqueous humor and the blood. This was published in Cancers by Amy Jarish, who's a scientist working in this field, and I thought it was nicely done. I don't do this work alone. I have a wonderful liquid biopsy laboratory team that helps me, and so I would like to thank all of them for their work, as well, of course, as our grant funding sources. These are my citations, which I'm happy to share with any of you, and thank you again for having me today.
Thank you very much. Very nice insights. Swati will discuss.
Thanks, Jesse. As always, I think every time I listen about this talk, there is always something new that I always pick up. So thank you for that. So I'm sure there are a lot of questions that are there related to this topic, because I think we are moving in the direction of personalized care for retinoblastoma for each patient. So I think the most important question that I would ask is, I know that you started off with doing the testing on the aqueous that you take while doing the intravitreal injections. At this point of time, we know that there is enough evidence that the aqueous is definitely useful to prognosticate the eye. So are you doing, even in those cases where you do not do intravitreal, just for getting a sample from the aqueous to prognosticate, are you doing that?
Swati, that's a great question. And yes, we are. So we have a full IRB approved protocol. It is, of course, a research protocol whereby we take aqueous at the time of diagnosis, as long as the chamber is formed. If the chamber is shallow, then we would take aqueous after the first cycle of IAC or systemic chemotherapy, whatever we choose for the patient. We take aqueous also at the end of chemo, during any intravitreal injections, and 6 months after the end of all therapy, in order to prove that the tumor is completely treated and there is no residual disease within the eye. I can actually just share with you, we were at ARVO, and so I was able to meet with my team. We now have 25 eyes from which we took aqueous humor at diagnosis. In those 25, we have 23 of them have detectable RB1 mutations. You know what both hits are because the tumor fraction is high enough to tell you. So you either have both RB1 mutations, or you can show that there's been loss of heterozygosity or a microdeletion, for example, of the RB1 gene on 13q. We also can detect the molecular chromosomal alterations for all. Now, in the two eyes that we did not, they were group A. We had multiple group B eyes. So even in tumors that are 3 millimeters, we can find this tumor DNA in the aqueous humor. And in multiple of these cases, it's a single patient with bilateral eyes, and we can show the difference between the eyes as well, which was recently published. So it's been very exciting. The diagnostic aqueous humor has a much higher concentration, and you can get really rich molecular information about the tumor from it.
Yeah, thanks, Jesse. So I can wait for much more information coming out in various publications in the coming months or years, I would would say. Thanks for that. So my next question would be, now we know that I think there is evidence that retinoblastoma not only occurs because of, we are basically studying the somatic copy number alterations in the aqueous and the somatic RB1 mutation, but how do we, is there any way that you're also looking at the epigenetic dysregulation that is actually causing, like, the retinoblastoma? Is there anything that is being done in that direction for the epigenetic changes?
Yes, Swati, you're so on it. I didn't prime you with this question, I promise. We have a paper under review right now looking at that, and we did publish this data at ARVO. As expected, the methylation signature that you can find in the aqueous humor is nearly 100% concordant with tumor. That makes sense, right? We're looking at the methylation of tumor DNA, so we would expect it to be concordant. It's further proof that the aqueous is a really viable and I think now proven alternative to direct tumor biopsy, which we can't do anyways in this disease. We've been able actually to show there's some very good work talking about signatures of high risk or more aggressive retinoblastoma versus low risk. And, the criticism, it was actually beautiful work, but the criticism of that work was, well, but yeah, you can't tell until the eye is enucleated, which was true previously, but now you can tell at diagnosis whether or not these patients have a certain signature of methylation. We're looking at validating that methylation signature again for high risk aggressive retinoblastoma versus low risk retinoblastoma. And I think that along with 6P, as well as maybe some specific RB1 mutations will all give us really interesting and informative information about which tumors are likely to be good or bad players. Other things to think of here, right? MICN. So our platform can very easily identify MICN amplification. We've published that. And Francis's group has published that. I see he's on here. Hi, Dr. Munier. And so that's quite clearly available. And think about some other oncogenes. So we have some patients that we've identified either MDM2 or MDM4 amplification, other known drivers for retinoblastoma. Again, 5 years ago, you would never know that until the eye was enucleated, but we can now identify these. So I really think we are at the cusp of starting to identify what specific drivers are are driving the tumor in each eye. Okay, the MDM4 amplification was in one eye and not the other of this patient. Why they are important, and move forward with actionable targeting of these alterations.
Thanks, Jessie. Great information. I'll just, if I may ask one last question, Dr. Honavar, do I have time for one more question? Yeah, thank you. So I think there's definitely great evidence that you have provided that chromosome 6p gain or even the MICN amplification, as all of us understand, has a poor prognosis. Now, what do you do in eyes that you detect that with your aqueous biopsy, you detect that the patient has chromosome 6p gain, and we know that by evidence that you have shown that it increases the risk of enucleation tenfolds. So how do you go about treating that patient? Would you advise enucleation, go for enucleation, or would you just continue the treatment that you're doing with just counseling the parents? How do you go about it?
It's a great question, and it's one that I struggle with as a clinician all the time, because of course I have a clinician and a researcher hat, so I know this. We are very strict right now that because this is research protocol, we aren't acting on the information right now. The 25 diagnostic eyes that I just mentioned are going to be part of a prospective validation. So we've shown this association with 6P. We've shown that was at the time of intravitreal injection. We now are looking to prospectively validate that 6P at diagnosis has that same impact on treatment failure. So right now we would continue our routine current therapy and salvage eyes that we think it's safe to salvage. I will tell you that we have some patients with bilateral 6P as well. And so I think that plays a role in terms of decision making. And I suspect we will come to a place, we talked about classification. Just like with melanoma, I think we will get to the point where both the clinical features as well as the molecular features of these tumors come together for a more comprehensive classification of eyes that are safe to treat and how to treat those eyes. So we're working on it.
Thanks, Jessie. I can certainly see that one day in the classification system, we would certainly have what is the aqueous humor results as well to classify the disease. Thank you for a great learning as always. And thanks, Dr. Power. I think we can move on to the next session. Thank you.
Thank you both so much.
We'll move on to Dr. Munya, who is joined now, and he'll be speaking to us on current status of management of witches and aqueous seeds. His discussant is Dr. Fairouz from Horus Eye Care, Bangalore.
Hello, everyone. Can you see my my screen?
Yes, Francis.
Yeah. So, greetings from Switzerland. It's a great opportunity. Thank you, Santosh, for inviting me and being virtually with you in India. So, the synopsis of my lecture is as follows. I will start with what I consider the two most significant publications on vitreous and aqueous seeding in 2022. Next, I will talk all what you need to know about aqueous seeding and its successful management. And then I will end with our 10-year experience with intracameral chemotherapy in Lausanne. So the first paper of great interest, in my views, is the paper by the group of Paula Szajkiewicz, and she is addressing the problem of how to deal with refractory vitreous seeds. And she's offering a great hope with this preclinical study, basically saying at the end of the day that, you know, a dose, we can triple or even have 5 times the dose we used to inject in the vitreous, because this 100 microgram human equivalent dose is not damaging, is not toxic to the rabbit eye. So I think this will be translated into the clinic shortly, and this is a great step forward, I think. Future will tell, of course. Second paper of interest regarding aqueous seeding, and this is a paper from India. And I recommend you to go and read this paper from Swati Kaliki and Saumya Jakati. It's extremely interesting. They, in a large, very large series, they do a clinical pathologic correlation for aqueous seeding. You have to go and see this paper. Now I will focus for the rest of my talk. I will focus on aqueous seeding. As you know, aqueous seeding can be classified into primary or secondary seeding, depending if it's present at diagnosis or during the course of conservative management. Until recently, this feature of seeding in the intersegment was always going to enucleation. Now, what you have to know, and anyone who has to deal with aqueous seeding has to know that irrespective to the type, class of seeding, you know, cellular infiltration of the aqueous spheres or even pseudo-hypopyon, you have to know that this is only the tip of the iceberg. And without knowing into more depth what is going on in the intersegment will not be enough to reach success management. So what I see as absolutely necessary is to equip the operating theater with, I have no interest, I declare that at the beginning, but to have an OCT, an inter-segment OCT in the OR, as well as an ultra biomicroscope at 50 megahertz. The importance of the OCT monitoring is to assess, there is now a way to assess with this tool, the Schlemm's canal. Because the Schlemm's canal is a vascular tissue, and if we can assess an invasion of the Schlemm's canal, I think it's a major risk factor for metastasis. So here is an example of such an eye with this section here that there is an trabecular growth of a seed that anchored at the level of the trabecular meshwork. But also you can also note that there is a clear, I don't know if you can notice it, but there is a clear demarcation line indicating at least that there is no invasion of the trabecular meshwork, and moreover, the Schlemm's canal seems to be totally free. And we were able to correlate the findings in the OCT findings and histopathology with Alexandre Moulin, our pathologist, comparing these two sections here at 9 o'clock and 4 o'clock. As you can see, at the 9 o'clock position, there is also a growth not only on the iris but also on the trabecular meshwork, but still with this demarcation line, nice demarcation line, which is not disrupted. The Schlemm's canals also seems to be totally free, and this was confirmed by the histopathology. In contrast, the 4 o'clock section, there was a clear suspicion here of a trabecular meshwork invasion and occlusion invasion of the Schlemm's canal, which was confirmed by Alexandre when he reviewed the section of the enucleated eye. Second, your UBM is also critical to assess and to document the type of growth in the posterior chamber. You will see in a moment why I think it's important to do that. And of course, to assess if there is an intraciliary invasion or invasion of the iris. So this, by doing this, you have to have a good knowledge of the microanatomy of the fundus extremicus. And for those who are interested into more depth, I recommend to go and see this data published in my paper 2019. So the growth pattern, there are of several types in the posterior chamber. First, you can have a growth in the Hanover canal, the space between the zonule and the equator of the lens. Then you can have an invasion of the Petit's canal, so in front of the pars plana, and you see the anterhyaloid here. It's a transverse section here, and you can see they can be present as nodules, but as these nodules grow, they can be confluent, and they can create such plaques, adherent without invading at that stage, without invading the pars plana, and these plaques, they are adherent between the anterhyaloid and the pars plana. They are, in my view, a risk factor for relapse of aqueous seeding. Another type of growth in the posterior chamber is what I call the interciliary process implantation. I refer to actually seeds that anchor between the ciliary processes, and these seeds are continuously washed by the secretion of aqueous humor and therefore resistant because they are underexposed to the chemo injected in the antechamber, posterior chamber. So they also, when you observe this feature, it's also, in my views, a risk factor for relapse. Finally, you have what I call the posterior iris implantation. You see, without invading the iris, you have like a plaque anchored at the posterior face of the iris, and this is also a risk factor for relapse. Now, of course, you can assess also the anter-uvea involvements. Here, iris involvement, and here longitudinal and transverse section of an intraciliary body invasion. Now, the technique itself for the treatment was described in this paper, and basically it's a safety-enhanced injection to prevent, of course, the tumor spread, as we described for intravitreal injection. Now, it's an aqueous replacement technique. So we empty you will see in the video, and we replace the aqueous humor with a solution at a known concentration, typically 20 to 30 microgram per ml of either topical or melphalan. And this is to prevent the aqueous relapse that we do it in those chambers. And then we concomitantly inject in the vitreous, because one of the most frequent mechanism of migration is transyelloid, and we do intravitreal injection. Now, this is the video. Oh, sorry. I hope the video will work. Here, yeah. So I will comment. So it's a very long passage with a 34 gauge needle in the clear cornea. A long passage that is a 2-3 millimeter passage in the cornea. Then we indent both the eye and the cornea, and you will see that doing so, actually the cells behind, you see, this is the loop, the effect. We have cells passing from the posterior chamber to the antechamber. We have changed the syringe to now inject a little bit in the antechamber. You see all the cells that move from the posterior in the anterior. Then we perforate the roots of the iris. Because of the long passage, the stability of the needle is excellent. We never touch the lens. And we inject in the posterior chamber, and you will see how we can also bring material from the posterior chamber into the antechamber. I think this is critical to have a limited number of injection and to be as efficient as possible. Then, of course, you have to cryo the entry sites. And at the end, we complete the procedure, as I told you, with an intravitreal injections at 3.5 millimeter from the limbus. With a 34 gauge needle as well. And
the time is up.
Oh, sorry. So I finish with my 10-year experience, just touch briefly where we are. The study design was all patients with between December 2011 and 2021 with at least 1 year of follow-up. So this is the population of 20 patients. And the good news is that we have an overall eye preservation rate of 85%, with a mean survival follow-up of more than 4 years, and all metastatic free. Also, the vision was useful to near normal vision in 82% of the salvage cases. So at least we can say that intracameral is safe, is efficient to control seeding, and of course you have to add, as necessary, additional treatments to control the risk factors I mentioned, the interciliary process implantation, etc., or intraciliary invasion. And toxicity is limited and not site-threatening. I have no time to develop that. So thank you for your.
Thank you very much. Feroz, you are on for discussion.
Thank you, Dr. Munir. Hi.
Hi.
I take this opportunity to thank you for your valuable contribution and giving us the courage to go into the anterior chamber and go into the vitreous chamber with your introduction of the safety enhanced technique. And this has really made life easy for us and our patients. We all agree to that. So thank you once again, and thank you so much for this excellent talk and the demonstration of the video. So I have, I'm going to keep it really short because we are running out of time. A relevant question that I have for you is, Dr. Munir, regarding the prognosis and the way of treating the intracameral and the intraciliary and the interciliary seeds. I'm sure like the intra would be more difficult than the interciliary ones. Yeah. What is the outcome and prognosis in your series?
Yeah. Sorry, I have no time to develop that in details in a 12-minute talk. But indeed, if you have, let's say, first, interciliary body implantation, this is a feature that is not so common, but in the 20 cases I mentioned, it was present in 4 of them. And to get rid of this tumor burden, because what is floating in the aqueous is easily controlled by the intracameral injection, but then you have a relapse from this part. And so the only way to control it is to put, in my view, a plaque in the meridians involved. And it's what we did successfully in all the 4 cases. Then for the intraciliary, similarly, it's also by brachytherapy that we have treated these. We attempted intra-arterial, but we were surprised to see that intra-arterial is not so efficient for intraciliary involvement. It was more efficient in the 9-3 o'clock position, maybe because of the long ciliary artery that are present in these meridians. But for the intraciliary component involvement that was at 6 or 12 o'clock, it was inefficient. So we had to put a plaque.
Okay.
Does it respond to your question?
Yes, definitely, Dr. Munia. One more question for you. So as far as the preference for the chemotherapeutic agent, topotecan versus melphalan, is there a preference that you have when you enter into the anterior chamber? Because, you know, it can cause uveitis, the corneal endothelium. We all know that melphalan is more toxic than topotecan. So do you have a preference in the chemotherapeutic agent when you go to the anterior chamber?
Yes, very good question. Actually, we have historically used more frequently melphalan. But I have to confess that we are switching to topotecan. It appears, of course, the series is very small, but it appears that we have more toxicity in the outer chamber with the melphalan compared to topotecan, especially cataracts that we observed in actually 60% of our injected cases, whereas it was only 20% of the cases injected by topotecan. Okay. But it's never linked to a lens touch of the needle, because the needle, remember, we have a long passage. We are actually in the Hanover Canal, or at least, you know, very peripheral, where the lens at the level of the equator of the lens, you cannot touch. If you have this direction of injection, you cannot touch the lens. No way.
Yeah, thank you very much. One last question. When you're going through towards the root of the iris, what is the chance of hyphema when you're injecting?
So we had in our series of 20 cases of spontaneous cases with 1 year follow-up, but we have more cases. We have 2 others that came up since that, and we have also a series of 5 cases with iatrogenic aqueous seeding. But in the total, so it's 27 cases, and we had only 1 case of self-limited hyphema. Okay, so it was only one case out of 27 that had we had just to press on the eye for a little while, and it was a self-limiting hemorrhage locally without hyphema.
Thank you so much for this valuable insight and sharing your data with us.
But I agree that, you know, you can have an associated rubeosis iridis, as you probably have observed when you have aqueous seeding. It can happen, and so you have to be very careful if it's there, because it's an additional risk for hemorrhage.
Thank you so much. Thank you so much, Dr. Munia.
Welcome.
Very nice update on intracameral chemotherapy, bicameral chemotherapy. Next speaker is Dr. Ralph Eagle, who is from Wills-Eye Hospital, Philadelphia. He'll be speaking to us on histopathology of retinoblastoma governing management in 2022. Discussant is Dr. Kaustubh Mule from Center for Zaire, Hyderabad. Ralph, you can share your screen.
Pardon me here. Okay, can you hear me?
Yes, Ralph.
Okay, Santos, thanks for allowing me to participate in this excellent symposium. We're going to talk about histopathology. Actually, we're not doing as much histopathology thanks to all your successful ice-sparing therapies. I have no financial relationships to disclose. Diagnosis, again, here's a few interesting cases that we diagnosed with histopathology. This is a 11-year-old girl from Hawaii who was thought initially to have granulomatous uveitis. She had a fine needle aspiration biopsy in Hawaii and eventually a nucleation. We saw the case in consultation. She had massive anterior segment involvement involving the ciliary body stroma, the anterior chamber, and the trabecular meshwork. This is interesting. This is the fine needle aspiration biopsy track in her cornea, showing lots of residual viable cells in the track, and that really emphasizes the importance of Dr. Mounier's cryo procedure for sticking needles in the eye. You know, again, he has shown that it is safe and effective if it's performed carefully. Here's another case, a 20-year-old woman from upstate Pennsylvania that found to have an abnormal looking eye, a pink mass in the periphery of the anterior chamber, dislocating the iris root. But the needle biopsy showed a small blue cell tumor with necrosis consistent with the retinoblastoma. So she was treated with intravenous chemotherapy quite successfully, but then was lost to follow-up. And again, she had a large retinoblastoma with massive uveal invasion. Here's the confirmatory histopathology. Histopathology, of course, discloses risk factors for metastasis. The classic risk factors, of course, include extraocular extension and orbital invasion, massive posterior uveal invasion, optic nerve invasion, retrolaminar onto the surgical margin, and anterior segment involvement. Here's a case, a really advanced group EI that was seen in the probably with advanced disease due to COVID, tumors filling the eye, extraocular extension, and massive choroidal invasion. Okay, histopathology identifies high-risk histopathologic features that are an indication for adjuvant chemotherapy. As you know, the COG ARET study 3321 was a prospective study involving more than 320 patients from the US and India. Indications for high-risk features that were indications for chemo in this study included retrolaminar optic nerve invasion and massive posterior uveal invasion. Again, example of massive posterior retrolaminar invasion. Again, if it's behind the lamina, it's outside the eye. This was an obviously massive case of massive uveal invasion. Again, what is massive? Well, the International Retinoblastoma Staging Working Group came up with a consensus definition I think you're familiar with. It's greater than 3 millimeters in maximum diameter or full thickness choroidal invasion. The COG study also found that 16% of their patients had retrolaminar optic nerve invasion and 12.5% of them had massive uveal invasion. I think that probably the most important thing from the COG study was this group of patients. They were patients who had the poorest prognosis, the poorest outcome. These are patients that had massive peripapillary choroidal invasion combined with 1.5 millimeters or greater of retrolaminar optic nerve invasion. There were 3 of these patients, and they all died despite having normal adjuvant chemotherapy. And this group of patients suggested that such patients might require much more intense chemotherapy. The Cobb study also found that the pathologists that contribute in institutions, which are often university-affiliated children's hospitals, improperly processed or misinterpreted the histopathology in about 20% of cases. High-risk features were not identified in some cases and were misinterpreted as being present in others. These are some examples of PO segments that were submitted to for pathology review. None for invasion, and one of them actually had retrolaminar invasion on the deeper sections. Some pathologists misinterpreted sub-RPE detachments by tumor as choroidal invasion. It's not choroidal invasion. And artifactual contamination was also misinterpreted in some centers. This case from our lab in Wills that was in the study actually changed the ACOG protocol and the standard protocol for dissection of eyes with retinoblastoma. In the initial ACOG protocol, the PO segment, the PO slide was submitted. This is the PO slide from our case, no high-risk features. Patient didn't receive chemotherapy. Several months later, the patients developed metastatic disease. We pulled our wet tissue, submitted the clots, and found this massive, greater than 3 millimeter area of choroidal invasion in one of the clots that was not seen grossly. So based on this, the COG protocol was changed, and we now bread loaf and both of the clots and submit them in addition to the PO segment and the transverse section of optic nerve as shown in this cartoon from Hans Gross-Nicholas. You also need good technicians that know what they're doing, that know how to make good sections that include the pathology that we want to look at. Another prognostic feature that's been reported recently is anaplasia. This is sort of a plus minus. It came out of the paper by P.M. Mendoza and Hans Gross-Nicholas's lab. And this is an example of a poorly differentiated anaplastic retinoblastoma, large pleomorphic nuclei with angular rhomboidal or fusiform nuclei with cell wrapping and lots of mitotic activity. Unfortunately, this anaplasia did not reach statistical significance in this study for death or metastasis, but it's thought to be still important. Histopathology rarely can provide clues to tumor genetics, particularly patients with RB1++ retinoblastomas. Again, generally accepted that the loss of both copies of the RB1 gene is responsible for initiating most cases of retinoblastoma. These are RB1- retinoblastomas, but about 2% of patients with unilateral tumors and negative family histories don't have RB1 mutations that are detected, and these are called RB1++ retinoblastomas. If you know, this is 2.7% incidence in over 1,000 cases. RB1++ retinoblastomas are poorly differentiated. They tend to behave aggressively. They're diagnosed at a very early age. They're always unilateral, they're sporadic, and the siblings are not at risk. They also have unusual cytologic appearance. They are undifferentiated cells with large, prominent round or oval nuclei with multiple nucleoli, apoptosis. They don't have much calcification. And interestingly, they don't have Flexner-Wintersteiner rosettes, which typically are found in eyes from young children. Here again shows the round and oval nuclei in the case we saw a few years ago with the nucleoli. And we compare a minus with a plus tumor in these. Again, these are probably driven by amplification of the MYCN gene that shows multiple copies amplified in a fish. And of course, the tumor cell nuclei are immunoreactive for RB1 protein, shown in the immunohistochemical stain on the right. Relatively recent case, a 26-year-old girl who had recurrence after IAC. It's the enucleated globe. When I was doing the histopathology, I noted this group of nuclei, the round with nucleoli, was suspicious that this might be an RB++ case. We got the clinical record and found that the blood test actually had been negative for an RB1 mutation. We stained the tumor with an immuno for RB1, and indeed it shows immunoreactivity for RB1, suggesting that it indeed is that category of tumor. Okay, we currently have less histopathology to review due to eye-sparing therapies. I recently reviewed 35 eyes enucleated from patients with RB that were accessioned by our lab between July 2018 and 2021. Interestingly, 71.4% of these eyes had been treated previously. I hate to be sarcastic, but I tend to call these million-dollar eyes, you know, where you spend $1 million and then take the eye out, but I hate to be so cynical, but again, 14 of the previously treated eyes contain no viable intraocular tumor. Again, previously treated eyes may have had high-risk features prior to therapy that are no longer detectable. So we'll just have to worry about that. And again, we in the past did a evaluation of 297 enucleated eyes with untreated retinoblastomas, and we found the incidence in Philadelphia of high-risk features was 18.5%. I'd like to congratulate Dr. Munier for his absolutely gorgeous clinical pathological correlations in his excellent talk. So thank you for your attention.
Thank you very much, Alf. Kaustubh, you're on for discussion.
Yeah. Thank you, Dr. Eagle. As you rightly pointed out, thanks to advances in treatment, we barely receive enucleations these days. And like you said, most of them are secondary enucleations. I have 3 questions for you. Now I'm going to put forward, the first one is about the number of sections from the central or peripheral calyx that we should ask a technician to cut before reporting. So there are 3 scenarios. The first scenario is that the tumor is confined to the retina. There is no local invasion. So before signing off a report, how many sections would you want to study before confirming that there are no high-risk factors? The second scenario is there is minimal choroidal invasion or invasion of only the optic nerve head or lamina cribrosa. Again, how many sections would you study before saying that there are no high-risk factors? And the third scenario is there is scleral invasion, which is limited to the inner 1/3. Now, before saying there is no extraocular spread or no full thickness scleral invasion, what is the number of sections that you would want to study?
Essentially, our technique, standard technique, is we'll do 10 H&E sections and 2 PASs from the PO block. Sometimes if there's more tumor, I will do a second non-PO AP segment with 10 plus 2. Then we bread loaf our culottes, maybe make maybe 4 bread loaf sections and do 2 and 1 in those. That's our standard technique. If if I'm worried about it, I will send back. I will get additional sections if I am worried about that.
Okay. Now the second question, which there was a case, there was a situation where you mentioned that about 14 eyes which were previously treated did not have any viable tumor. So my question is about the same situation. Now, if in an enucleation, a pathologist sees only amorphous calcific deposits and necrosis? How would you report it?
Well,
How would you sign off the report?
No viable tumor. If I don't see any viable tumor, I'm going to, but I'll mention that there is a treatment regression scar consistent with prior therapy. Again, one thing I didn't show is that 75% of the previously treated eyes did have obvious treatment regression scars. Sometimes you'll see a little bit of retinocytoma-like tissue at the margin of the regression scar, florets. There's another variant of retinocytoma where you don't have to have florets.
Okay, thank you, Dr. Eagle. And the last question, this is about the paper by Dr. Mendoza and Dr. Gross-Nicholas about anaplasia. How important is it to report on anaplasia in secondary enucleations?
In secondary nucleations, I have a problem with primary nucleations sometimes. I have the case I showed you. Was a slam dunk, horrendously anaplastic tumor. But the problem is that it's so. It's difficult. One criticism of that paper, I didn't think that their photograph examples in their paper were particularly good. Again, I will comment if there's obvious anaplasia. I have not had the separated with the pre and post treated cases. It's just if it's there, I'll comment on it. The question is, how important is it?
Okay, thank you, Dr. Eagle. Thank you, sir.
Thank you, Kaustubh. Thank you, Dr. Eagle. We'll move on to the next talk. That's by Dr. Helen Demaras from Sick Kids, Toronto. She'll be speaking on how can genetics help in the management of retinoblastoma in 2022. Discussant would be Dr. Usha Kim from Aravind Eye Hospital, Madurai.
Helen, you're muted.
Thank you. Sorry, that is a very rookie mistake. Thank you so much for the invitation to speak today. We've heard so far many of the talks reference genetics, and I think that's owing to the fact that cancer is a disease of the genome, essentially. And retinoblastoma, in fact, was the first cancer that brought this issue to light. So we all know that the majority of retinoblastoma tumors are associated with the RB1 gene located on chromosome 13. The gene itself is involved in controlling cell growth, preserving genome integrity. So you can see how loss of these functions is really advantageous to a growing tumor. And so we know that loss of both copies of the retinoblastoma gene is important to initiate tumor development. In many of the references, you'll see this termed as M1 or M2 for mutation 1 and 2, although now we generally refer to these as pathogenic variants. And the timing of when this occurs in the development of the individual will essentially dictate if that case will be heritable or non-heritable retinoblastoma. And I'll get into that in a minute. Dr. Eagle spoke of the MYC-N variant of retinoblastoma. And so this is another rarer form of retinoblastoma where, in fact, the RB1 gene is completely intact. And this gene is located on chromosome 2. It's an oncogene. It regulates cell growth and division. And in these classes of retinoblastoma tumors, too many copies or amplification, even more than gain that we're talking about when talking about the somatic copy number alterations in tumors. This is 20 to 100 copies we've seen, and this is enough to drive tumor initiation. At the level of heritability, we can start to see where these genomic origins of the tumor fall into which class. And so All heritable retinoblastoma is affiliated with the loss of RB1, and it's heritable because the M1 event occurs at the constitutional level. And so this M1 can either be inherited from a parent, whether or not that parent actually manifested with retinoblastoma, but in the majority of cases, it's acquired early in embryonal development. When we look at phenotype, all bilateral cases are heritable. It points to the heritability. But we also know that some, 15% of unilateral cases are also heritable. And the presence of this M1 at the constitutional level confers second cancer risk, family members at risk. In fact, you would also monitor the unaffected eye of a unilateral patient in this category for development of tumor in the second eye. Whereas the non-heritable class of retinoblastoma has normal constitution, normal germline. And so this is most unilateral cases caused by RB1. So the M1 and M2 event happens at the level of the retina only. And MYC-N is also always acquired. And the amplification is also somatic in that tumor. When we talk about the timing of the constitutional event, the M1 early in embryonal development, we also know that this isn't, if it happens a little bit later in development, here I've shown a 4-cell embryo where the, excuse me, the initiating event that causes M1 only occurs in a fraction of the embryo. This later manifests into what we know as mosaicism. So the M1 affects a fraction of the germline cells. Retinoblastoma may develop in one or both eyes, maybe no eyes. Often we see when we go back and test parents and find that the parents are mosaic but never had retinoblastoma. We don't know just from the percent mosaicism we find in the blood what their precise second cancer risks and heritability is for the next generation, or even second cancer risk, as I mentioned. So this remains a question to be answered, and we're getting closer. And then, of course, that's only enough to initiate the tumor. For RB1 minus tumors, whether it's acquired or at the constitutional level or the somatic level, this is only enough to lead to retinoma. And other genomic events are required for malignant progression to full malignancy. We see some of these events at low level in retinoma. These involve chromosomal gain at 1q, 2p, 6q, 7q. And through the study of enucleated eyes over the last 30 years or so, we know what genes might be driving tumor progression. So at 1q, there's KIF14, MDM4. MYC-N is actually also present at a lower level as in the RB1 minus tumors, though not the driving factor. 6q, which was mentioned earlier, we know that DEC and E2F3 might be important targets. MicroRNAs at 7q, and a loss of chromosome 16q is affiliated or associated with cadherin 11, which promotes cell-cell adhesion. There's also a pathogenic variant of BCOR that's been associated with progression, as well as epigenetic events as well. And so further research into exactly how these work, at which stages of tumor development, and what drivers or what targets we can use to interfere with malignant progression will be important areas of research. And also in terms of the MYC-N tumors, we don't know if there's additional genomic events. The research thus far seems to indicate MYC-N amplification is sufficient for development of MYC-N tumors, but of course, further research can delineate that for us. And so that's the genetic development in a nutshell. But what does this mean for the patient? And the title of the talk is, how can we use genetics for management of patients? And so for here, we can think about the patient that appears in the clinic, and where is genetics going to be useful? We've talked about how genetics is useful for precise diagnosis and perhaps treatment as the child grows. going back to the parents and identifying their risks and the rest of the family. But of course, knowing the heritable status of this child will affect family planning as they grow older, diagnosis and treatment of the next generation, and also monitoring of this patient as they grow older for second cancers. And I'd like to go through some of the technologies that are available right now, where research is actually budding to make it even more exciting for the future of retinoblastoma patients. And hopefully that generates some discussion. And so I just wanted to point out that genetic testing precisely identifies risk. We talked about how phenotype can give us some idea, but it's not the full picture. For example, we know that a bilateral patient has heritable retinoblastoma from the phenotype, but without genetic testing, we don't know the precise way RB1 is altered, and therefore we don't have the key to unlocking and screening family members or future children. Similarly, if a unilateral patient appears at the clinic, we don't know if they're heritable or non-heritable. We heard Dan Gombos give an example of how some unilateral patients are lost through the cracks because their doctors might tell them, well, you have unilateral, therefore your germline is not affected. That's not true. We need to know if the other eye is at risk, and we don't know that. We can't counsel on second cancer risk. We don't know if family members are at risk, and we can't differentiate between McCann A or RB1 minus retinoblastoma. I have the asterisk there, of course, because Dr. Eagle just showed us there are distinct histopathological markers that can give us that information, but of course, only if that eye is enucleated. The importance of genetic testing and really drilling down the genetic makeup of the patient and tumor has been acknowledged by the AJCC TNMH staging. Ashwin didn't quite get to this, but AJCC staging for retinoblastoma is the only one that acknowledges the heritable trait as part of classification. And so when there is no genetic testing or not enough in the family history and phenotype to be able to give that genetic diagnosis, we call these cases HX. When high sensitivity genetic testing is available so that we can say with certainty that the RB1 alleles in blood are normal, then that patient is H0. And H1 would be any bilateral patient, retinoblastoma with a trilateral presentation, family history, or the molecular definition of a constitutional RB1 gene mutation, then they're H1 or heritable classification. And so genetic testing, therefore, can really help us drill down the precise diagnosis for the patient, screen parents, children of the parents or siblings, as well as be used in future for the next offspring. And so that's where I want to take a look at next. Actually, first counseling. So Dr. Gombos also mentioned how counseling goes hand in hand with genetic testing, because patients need to know what this means and to be active partners in their life course so they can access these services as they need them as they grow. Of course, genetic counseling is not consistent around the world. Some places, maybe there is no genetic counselor and the message is conferred by a doctor or nurse with various levels of training. We talked about how the message can either be something that's based only on phenotype, which is imprecise, or with high sensitivity genetic testing. And so the message to the family really depends on how precise that initial genetic diagnosis can be. And of course, there's patient-specific factors on how they understand and are able to act on that information. And this depends on sociocultural context and individual levels of stress and coping. As many families have told us, this information is quite difficult to deal with, particularly in a heritable genetic diagnosis. And so here's one example from Kenya, where families collaborated with clinicians to develop a tool, a genetic counseling tool that simplifies the genetic origins of retinoblastoma. It was created in English and in Swahili. And this simplifies the various aspects or various pathways to retinoblastoma by pedigree, and with the help of a practitioner, a nurse, or a clinician, the family's individual genetics can be demonstrated through the use of these visual aids. And this is currently under study. And so back to To our patient life course in genetics, I've added the importance of tailored counseling protocols and tools as something that's research and development to support management of the genetics of retinoblastoma. Also, we know from past research that these tumor-specific mutations, or even the RB1 mutation in the case of a non-heritable patient, can be used to screen for metastasis. Also the M3 to MN signature in past has been used to screen for presence of minimal residual disease in patients with high-risk retinoblastoma. And so this can be used alongside traditional histopathology for surveillance of the patient with high-risk disease. As the child grows old, see, I keep skipping ahead. Jessie very nicely told us about her work in liquid biopsy. And this actually is a great new step where we can biopsy the tumor as it's being managed and treated before enucleation. And with further research into those M3 to MN events, which we know we can detect through this technique, we could maybe see a future of precision care. And so I've got liquid biopsy here as research and development for management of patients, but also leading to precision care in future as we figure out how to target these markers of advanced disease. And also understand a little bit better what are the responses of the tumor during treatment. Does the genomic profile change or any other biomarkers appearing as treatment proceeds? And so that's a very exciting area of research. Currently, for the next generation, we can do prenatal genetic testing with retinoblastoma. At sick kids, prenatal detection of RB1 is coupled with near-term delivery. We find that there are fewer and smaller tumors than when the child is first screened, leading to simpler treatment and better chance of saving life and vision. Prenatal genetic testing is done either by amniocentesis or chorionic villus sampling. It does have some small risks to the fetus, although quite safe. And in our experience, we can use OCT to detect tumors before they're visible to the naked eye. And our study comparing those with prenatal detection compared to those without shows that the percent avoiding failure is much higher when prenatal detection is coupled with near-term birth. So that's something that's available right now. From the UK, we see a new way of prenatal testing non-invasively, so avoiding the rare risks associated with amniocentesis or chorionic villus sampling. And this captures cell-free fetal DNA in the mother's blood. And the mother's or the father's RB1 mutation is used to screen that cfDNA. And I heard this week that this test is now available to all familial retinoblastoma patients in England by the NHS. So that's an example of research leading to a new opportunity to manage familial retinoblastoma cases. In one of the questions earlier, an audience member asked about in vitro fertilization and pre-implantation genetic diagnosis. And so this would be for familial retinoblastoma cases who wish to prevent retinoblastoma in the next generation. And so they would undergo IVF. The embryo would undergo a biopsy to screen for the parent's RB1 mutation, and only the unaffected embryos would be implanted, taken to full term, and thereby avoiding retinoblastoma in the next generation. And as we talked with the audience, with the panel, some clinicians would still screen this child just to alleviate any discomfort or worry that something had gone wrong. Of course, there would be nothing to prevent the team from also doing a second genetic test to screen the baby's blood for the familial mutation to know for sure that this child is no longer at risk. And so in this scenario, pre-implantation genetic diagnosis could prevent retinoblastoma in the next generation. And finally, where are we at for second cancer screening as our retinoblastoma survivor grows into adulthood and older age? there's some exciting research coming out of looking at individuals affected by hereditary cancer syndromes. This is the CHARM consortium in Toronto. It's the Screen cfDNA in hereditary and high-risk malignancy groups. And the Sick Kids Retinoblastoma team is now working on a collaboration to add retinoblastoma survivors to this consortium. Our survivors are very engaged in Canada in research, and in fact, one of the top priorities is to figure out how to monitor for second cancers. And we've certainly had a lot of research over the years to try to monitor with various imaging modalities. And now we have the very real possibility of screening for circulating tumor DNA throughout the life course of an individual. And that's exciting research coming out. And so here's our summary. We've got a number of available genetic tools in blue, a lot of exciting research that will enhance our abilities to use genetics for optimal care of patients and their future families affected by retinoblastoma. In summary, we've covered the two main ways that retinoblastoma is initiated, either by RB1 loss or MYC amplification. Genetic testing is important to distinguish between heritable and non-heritable cases and used to screen for at-risk family members. For the next generation, prenatal diagnosis and early delivery can predict retinoblastoma and reduce morbidity. IVF and pre-implantation genetic diagnosis is an option to prevent retinoblastoma in the next generation. And the post-RB1 loss molecular signature is a good surveillance mechanism for disseminated disease, but detected via the liquid biopsy has real potential in future as a prognostic biomarker for eyes undergoing active treatment. And future research really holds promise for molecular second cancer surveillance. Thank you very much. I'd like to acknowledge the Sick Kids RB program, who we talk many times about genetics research and clinical care. That's Ashwin, who now leads the program, taking the torch from Brenda Galley, as well as our new team member, Stephanie Kletke, pediatric oncologist for Ken Shake, and our genetic counseling team. Thank you.
Thank you so much, Helen. You have been a leader in this field. Wonderful talk. Usha Kim from Arvind Eye Hospital, Madurai, who will lead the discussion.
Thanks, Dr. Helen. That was an excellent, extensive overview of the genetics. I don't think I have much to add to it, only that I can share what we've experienced in the past, I should say a decade, with the experience of doing genetic studies in about 550 probands and their families. So what we found out is that 90% of the, we were able to detect the mutation in 90% of bilateral cases, both in the blood and tumor, and about 95% in unilateral cases in tumors, which is the enucleate size. And then had about 20%, this is what I felt was very significant, 20% of the unilateral mutation was found in blood, which means they are the ones who are going to be heritable. So this unilateral again, which only means that we have to do a genetic studies in all the cases and not just follow the same old principle of bilateral having to do the genetic testing.
Absolutely. And I appreciate how you describe the results by separating out the bilateral and the unilateral. I think that's something that's missed in a lot of research that even gets published. And so it's really important to distinguish that sensitivity between testing bilaterals and unilaterals.
So for us, it was like we did the entire spectrum from point mutations to whole genome gene deletions. And also we did the MLPA. We found out that we had many of the, reported ones, but apart from that, we had a few, very discrete ones, which were very specific to our particular cohort. So that was something we found out in our, genetic analysis. And we also had a few mosaic variants too. And for the prediction, as far as the clinical implications goes, we were able to predict for the other eye. Then we were able to predict for the sibling, the offspring, the twin. And then we also could do a prenatal testing for the fetus. And to a certain extent. The secondary tumor part, since it was not, the mutations were not in the blood, we were able to tell the parents and the patients sometimes that there may not be a risk of a secondary tumor to a certain extent. And the other interesting finding was we found out 3% of the cases had promoter methylation. So that was another interesting feature we also came across. The only thing I wanted to ask you is, are you doing any work on the chemo-resistant cases? And what is it? Yeah.
We aren't at Sick Kids right now, but we are expanding our biobank to collect our cases systematically. Because of course, a lot of research is dependent on studying either, now we have the opportunity through circulating tumor DNA as well as through enucleated eyes. We do have a collection that we would like to study. I think what we're recognizing is we need to be following international standards on the collection and storage of specimens, and only then can we really start comparing between all our different centers. So I think we've taken a little bit of a slowdown to make sure we're matching our, international standards. And this type of study would be really excellent if we can get all our groups around the world involved to really identify the unique genomic characteristics maybe of different patients around the world, which haven't been acknowledged or even studied before.
And what about the role of cancer stem cells? Any work on that aspect?
We haven't done any of that at Sick Kids yet, yeah.
And the other important factor, at least in India, is the implications of counseling. It could have a very bad social implication. So I think it's best to keep the counseling very clear and crisp, because there are many patients who come to us and, Google gives all the information. And there are parents of the grooms and the brides coming and asking the implications. And we'll have to be very, very careful about how we spell out the results. I think that's very important as far as the social implications are concerned.
I agree. And cultural implications of genetic counseling. And I think we're going to have to really work with patients who, maybe even families who have familial retinoblastoma cases in different contexts, to tell us what those implications have been for them and advise us on how maybe we alter our protocols. In Canada, our patient engagement group is really helping us in that regard. And in Kenya, we've made some really good advances by really listening to the patient view. It's a give and take. Sometimes we think we have the answers on the clinical side. We're acting to protect our patients, but with some more understanding, perhaps the information we might be withholding because we want to avoid social negative consequences might actually be delivered in a safe way that helps them manage their care better. So that's a huge area of research as well.
Thank you so much, Dr. Helen. That was really good. Thank you.
Thank you,
Dr. Santosh, if you allow, can I ask one question?
Can we just move? Ganga is in a hurry to go to another meeting.
Sure.
It's okay. It's okay. Carry on, Seema.
Is that okay, Ganga?
Yeah, of course.
Okay. This is both for Dr. Jamaras and Dr. Usha. So what is the sequence of your testing? Like, do you do sequencing, MLPA, and also methylation for all your patients, or methylation only after kind of, the other two turns out to be negative?
No, it goes through the same sequence as you mentioned. We would be doing it. Even if you find out some mutations that are part, sequencing doesn't give a full answer sometimes. You might have to go through all the steps, and then you'll have to come up with the final. I'm sure Dr. Helen has.
Yeah, so the testing is actually done offsite at Impact Genetics, which used to be called Retinoblastoma Solutions. And they have a variety of techniques to look at the sequence, small deletions. They look for recurrent mutations. They have an algorithm that goes through the, where to start first and deduce, what's likeliest to have a hit first. They look for splice mutations, a number of different things. And of course, there's also karyotyping, which is important in a small group of patients to detect large deletions of protein Q. Yeah.
For the point mutations, you'll do the Sanger sequencing. for the point mutations.
And do you do methylation for kind of,
yeah,
all the patients before you actually label them as sort of germline?
Yes.
Okay. Thank you.
Thank you so much. We'll move on to Dr. Gangadhar Sundar, who is from Singapore. And he's going to talk about retinoblastoma in Asia, and his discussant would be Dr. Seema Das from Shroff Charitable Eye Hospital, New Delhi.
Thank you, Santosh and Fairuz and Team AIOS for organizing this on the occasion of the World Retinoblastoma Week. I think it's starting tomorrow. And hats off to all the pioneers who have paved the pathway for our better understanding and management. A big thank you for training Dr. Santosh Honavar, who has completely transformed the way we understand and manage retinoblastoma. So thank you very much. Greetings from Barcelona. Warm Barcelona. It's a lovely, bright evening over here. I'm here for a facial trauma conference. But I'll share my personal perspectives, what I've experienced in the past 18, 20 years since I moved to Southeast Asia. People talk about the global burden of retinoblastoma, but actually when a patient comes to us, if we see a disease as a burden, then it conveys a negative image. And I think as all of you are pioneers and leaders and masters in the management of the disease, we have to probably change the word of burden to the joy and the satisfaction that we get from delivering very good outcome. The major problem is that it is relatively a rare disease, and hence even departments and institutions and even governmental organizations sometimes don't pay as much regard to this disease, whose incidence is 1 in 12 to 15,000 live births, resulting in a global incidence of about 9,000 a year. But what is most important is 4 billion of the 7 billion population lives in this part of the world, and hence these kind of webinars and conferences are very important. I'm not going to touch about what happens in India and China, but these are big countries where the retinoblastoma is managed uniquely. But what I'm going to touch upon is my personal perspective on the Southeast Asian perspective. Neither do I have a conflict of interest, no interest in conflict that we see in this part of the world. Of course, the only conflict I'm interested in is where it actually fosters science and knowledge and discussion, education, and helps humanity. So it is really a success story. A 90% mortality disease has transformed to a 90% survival disease. I would probably dare say it's probably the most curable malignancy. And the treatment paradigms has always focused towards life first, followed by globe and vision. But I'll probably qualify it and redefine it a little bit more as we go along. We at NUH Ophthalmic Oncology Service draw patients from all these countries that I've highlighted over here, including Pakistan, Russia, and a few other countries. With our birth rate of only about 45,000 babies every year, we see about 2 to 3 babies, but about 12 to 15 patients that we see from the region almost every year in the pre-pandemic era. And this is our NUH retinoblastoma team. We have our pediatric oncologists here, two retinal surgeons here, pediatric ophthalmologists here, and hiding silently behind us, the intra-arterial team, Dr. Anil from the neurointerventional radiology team. We used to take a lot of pride in saying that, yes, we manage this disease very well. Yes, this child post-enucleation with a prosthesis, customized prosthesis, and this is how we are managing it in the early 20s, and we said, yes, we did a great job. But what has transformed in the past about 8 to 10 years, at least here, is now with the introduction of intra-arterial chemotherapy, we are not only saving eyes, lives, globes, and even vision is being restored. And this has been really gratifying, as Dr. Carol Sheets was demonstrating earlier on. So how did we get here? We started off with enucleation, external beam radiation therapy in the 20s, 50s, cryo and photocoagulation came in, and the Shields, I think, kind of introduced the concept of chemotherapy, but we now call it chemoreduction. And of course, Dr. Munier and all the other pioneers have taught about intracameral, intravitreal chemotherapy and entering the posterior chamber of the eye through the cornea are all fantastic ways of doing it, but there's still a role for enucleation in some of these patients. So what is the problem with enucleation? Because in the past, the ophthalmologist just enucleated an eye, said, I've done a curative procedure. But now in the modern context, number one, these are potentially avoidable. And that's why it leads to a lot of conflicts between the patients and their families and the primary ophthalmologist who only offers enucleation as a therapeutic intervention. There are numerous barriers which can be societal, religious, psychosocial, economic barriers, and that kind of varies from the country to country, from where our patients come from, depending on even the religious background, where they are averse to having any organ being removed from their body. And if the organ is removed, they actually want the organs back for burial purposes so that they can meet the religious requirements. The third major challenge is this issue of the family, and usually the Asian context is an extended family. In other words, the family is no longer the child and the father and the mother, but the uncle and the aunt and the neighbor and the grandparents, all of which adds to the complications that we face in the discussion itself. And a major complication that we also encounter is the ego of the primary ophthalmologist, the surgeon, he or she who actually stands their ground and insists this is the only way to treat the child, when the parents now in the internet era are able to go read up on Dr. Google and find there are far better ways of treating the patient and the child without necessarily having to remove the eye. So that's an important barrier that we see in this part of the world. And finally, most importantly, there are patients who end up having deaths despite enucleation. Dr. Ralph Eagle showed that the importance of high-risk characteristics. So if you did not have a dedicated ophthalmic pathologist, you did not define this, you just remove the eye, send the child back to the village saying that you're cured, and lo and behold, the patient has intra-orbital disease, intracranial disease, and death. That conveys a wrong message to the patient and the family that even after removing the eye, the child is probably not going to be cured, and hence it's a barrier for enucleation. There's no active monitoring of the cut end of the optic nerve. There's no follow-up post-enucleation in some of these patients. And pre-enucleation staging errors where people end up doing a CT scan, not an MRI. And MRI, they don't really visualize the intracranial structure, including looking for the trilateral retinoblastoma, but only image the orbits looking for orbital extension. Here are examples of patients where children have been cured unilaterally. As you can see over here, even this patient's even had radiation, the residual consequences of the face, or a child who came to us post bilateral enucleation as the only treatment modality that is offered. When the parents came to us for a second opinion, what else can you do except to rehabilitate this child? Hence, enucleation is not the end of the story, even if you cure this child. So I always believe that when you do an enucleation, the life, globe, vision, then socket rehabilitation becomes a very important armamentarium in the tool in the management of retinoblastoma when the child has to go back to the school, not disfigured. So there are papers which we talked about the differences between the developed and the developing nations, the average age of diagnosis in a developed or high income country compared to a low income country. The incidence of orbital disease is far much more in the low income disease itself and extraocular disease. So these are very important perspectives that we still see in this era, even the 2000 era. And if you look at, except for barring India and China, there's approximate incidence and number of cases that we see in this part of the world. And we see about 3 or 4 times the average incidence that we see in Singapore itself. And this is the group of patients that we end up either offering telemedicine consultations or management, and a huge slew of challenges that we face in this part of the world. So how do retinoblastoma kids really suffer in this part of the world? In Asia Pacific, where there's no formal training for ophthalmic oncology, there's no ocular oncologist. Children often suffer from sometimes no management at all because the diagnosis has been wrong, or they've been offering the wrong treatment. They have been incompletely treated, or they end up being poorly treated. And there are a lot of these physician factors equally to blame as the patient family factors. Here's an example of a child who came to us then in the pre-IAC era with an advanced group DE retinoblastoma. The other eye is completely normal. We managed with the enucleation. And based on the history that the first child had indeed ended up having an enucleation, this is a post-enucleation retinoblastoma with orbital intracranial extension where the child had died. And based on that, when the family had a third baby, neonatal screening and acute screening in the first 2-3 months, we were able to identify the child's early lesion and treat it with local consolidation therapy without systemic chemoreduction. Here's another child who was actually referred with a retinoblastoma, but actually it was not a retinoblastoma, had undergone intravitreal injections for quote-unquote retinal disease or Coates disease because he was a 5-year-old child. The retinal surgeon did not think of a diagnosis of retinoblastoma. And by the time he came to us, he had extensive orbital disease, metastatic disease, and finally the child died. And a third example of a patient who actually had extensive orbital disease, Dr. Honavar has published beautifully on orbital disease and how it can be managed. Here's a child running around the family where the chicken were literally picking on the maggots, which is on the surface of the lesion, where we actually debulked the tumor completely, instituted high-dose chemotherapy based on the protocol. But when he went back to the village, based on the complications of the chemotherapy, which was not being monitored by the primary pediatrician and the pediatric oncologist, the child ended up succumbing to the disease itself. So the factors that we face are challenges are physician factors, where either the pediatricians or the family physicians either are not aware of the diagnosis of retinoblastoma, or they tell the child, don't worry, it's just a strabismus, can be fixed later, send the child back home. Or sometimes they end up seeing an ophthalmologist who's not a pediatric ophthalmologist or oncology trained, who ended up misdiagnosing and sending the child back home. There may not be facilities for anesthesiologists to give examination to anesthesia. So that's why we believe even a sedated examination saves not only the cost, but morbidity of these patients. And finally, the physician ego factor. In addition to the patient factors and system factors, where not every institution has multimodality, multidisciplinary teams, and it takes an effort to build these teams, which sometimes it takes 5, 7, 10 years to find the right person in every specialty. And finally, cost consideration and technology considerations, because cryo, laser, although they're not that expensive, sometimes are deemed as expensive technological treatment therapies. And of course, IAC is a new factor, which I think was talked about by Dr. Mahesh. What are the factors, again, which cause challenges in management? Diagnosis or misdiagnosis of true versus pseudoretinoblastoma. Grouping and staging are oftentimes not well understood and not well performed, both clinically and radiologically itself. Management is oftentimes suboptimal. And of course, the most important thing is follow-up. Just enucleating or treating the child and not making them come back for regular follow-ups results in challenging disease. We do have cases where they're rightly diagnosed, but have inadequate management, where because of incomplete treatment of the retinal tumor, child, instead of coming back in 3 weeks or 4 weeks or 6 weeks, coming back for regular follow-up, disappears for 6 weeks, 6 months, and comes back with extensive disease, where they start treating with focal treatment when it's not going to work anymore. Sometimes the diagnosis is right, but the management is wrong, and every once in a while it's a wrong diagnosis. What are the system factors? And this is personally what I faced as well. It took about 10, 15 years for me to motivate one of our own residents in our own residency program to pursue the concept of ophthalmic oncology. Doesn't make easy money, and it's a lot of hard work. It's passion which drives you to do it. Concept of an ophthalmic oncologist who's both comfortable with both intraocular and extraocular disease is very important. The government priorities of focus towards rare diseases is very important. Sometimes they pay attention only to the local patients, but not to the foreign patients. Not all ophthalmic institutions have support services for pediatric patients. And finally, the ophthalmic and oncology partnership or the multidisciplinary teams. And that's a team that I'm now very proud of. We now have a young bunch of pediatric ophthalmologists, young vitreoretinal surgeons. Dr. Gopal has been guiding them. Pediatric oncologists, we have an interventional radiologist on board. Like the pathologist, ocularists need is becoming lower, but we still do it. That finally the pathologist and the geneticist. So what are the suggestions to overcome the challenges here? These kind of conferences and webinars, especially in the COVID era, is very, very important. We need to have formally trained ophthalmic oncologists, like every one of you who's got wonderful training. We've had the Shields over here who have trained Arun Singh and Fairuz and Santosh and several other people, Dr. Abramson, Dr. Geeta, for example, who's trained Kaustav, for example. These are the people who really should be transforming the way Asia-Pacific retinoblastoma management is concerned. These are the retinoblastoma programs we've had over the years, and we're going to be having one very soon. So in summary, I would say that retinoblastoma should not be seen as a burden anymore, but actually a joy and satisfaction to treat. Encourage young people to take up this. It is very satisfying when you manage it very well with a multimodality, multidisciplinary approach. Also, the take-home message is enucleation, not the end, but merely a step in the management of these patients as well. And finally, when you have to enucleate, do not forget that socket reconstruction is just as important as enucleation in confirming this management. Thank you very much for the kind attention. And I'll end up with this slide from Barcelona over here with Anthony Gaudi, where this building is ongoing work for the past 10 years. To do something right, first you need love, and I say passion, and then technique comes in. Thank you very much, and I invite you all to our retinoblastoma symposium, which is happening very soon. Thank you very much.
Changa, very nicely put. Seema, ready to discuss?
Thank you very much, Dr. Ganga, for sharing your experience and also suggesting a solution. This is something which is so much relatable to what we see in India. It's almost the same story and the same scenario most of the time. So I would just like to share our experience and a few interventions, what we are kind of currently doing to sort of tackle these issues of the non-clinical factors, the barriers so-called, which comes in the way of giving an optimal treatment to these patients. So these are some of the stories I'm sure all of us can relate to that. This child was in fact saw during the COVID time, where the child was diagnosed when the tumor was already inside the eye, and as part of the protocol, he was sent for an MRI. Now the MRI center, when the child went, was shut down because of COVID, because they were not giving anesthesia. So, and they didn't bother to kind of go back to the treating physician or find out an alternative center. So they came back after 9 months after the lockdown was over, and that's when the MRI was done, and this is what the picture is, and we know the outcome. So a lot of lack of awareness, and even the diagnostic facilities are something which is a big hindrance, at least at the initiation of the treatment. Other scenarios like this family has a father, both are enucleated, 2 siblings at presentation, bilateral retinoblastoma, who offered a prenatal diagnosis when the mother was expecting the 3rd child. Though it was positive, we explained the prognosis. Despite that, they refused a termination of pregnancy and went ahead. But fortunately, we knew that this child is going to have to treat it on time and pick it up on time. But for this child, every time, you can imagine the number of times they had to shuffle between the hospital and home. And every time we had to support them, not only with the sort of, lodging, accommodation, food, but also with the transport. Otherwise, they just refused to come for the treatment. So again, very familiar scenario, which I'm sure many of us might be facing, at least in this part of the world. Other thing which you have highlighted, residual tumor following incomplete surgery, because many times the protocol of treatment is not followed. And this is the picture after the chemo reduction when we started the child, and we can clearly see the whole optic nerve there. And this was an eye which was possibly eviscerated, not even enucleated. So there are a lot of issues which includes right from breaching protocol, lack of awareness, and other barriers. And one of the intervention that we are planning under the aegis of the retinoblastoma stakeholder group is to plan a prospective study to see the epidemiological and the clinical features and what is the outcome if we all can follow a standardized protocol. So we started, the study was started towards the end of 2020. It is still enrolling patients. And one of the objectives of the study was not only to kind of see the outcome, but as the study is sort of, held by CanKids, and this is under the aegis of the Indian chapter of the pediatric oncology, the research wing of it. In fact, Dr. Santosh is the PI of the study. One of the objectives is if we prospectively follow this patient, we might be able to do the intervention if there is a barrier. We might be able to identify it and then kind of address the barrier. So this was the major objective. And right now we have 19 centers. Most of the major centers treating RV in the country who are enrolled for this study. As of now, we have enrolled about 530 patients, and we still have the data which are kind of yet to be analyzed, but preliminary, what we see, 20% still have extraocular representation, which is what we also tend to otherwise see in our clinical practice. The figure might be a shade better than what it was maybe 5 years back, but 20% extraocular is not something which we need to kind of see. Good part is, as of now, though, just about a minuscule of them have completed treatment, just about 8%, but as of now, the treatment abandonment has been just 2%. So we are keeping our finger crossed, and we need to see when these patients follow up, whether all of them are able to complete the treatment and get a protocol-based treatment or not. This study, the genesis of this was actually our experience in supporting these barriers. And this was what we did after the experience of the COVID. And this is our 1-year data about what we found when we sort of, a little bit of more hand-holding is done for this patient in terms of, travel, accommodation, investigation, and most important, the counseling, which is aimed at improving the compliance. So over a period of, this is our data of 2021, and what we found that out of the 73 children which we could treat in this period, our compliance earlier used to hover somewhere about 80% or so. But when we identified some of these barriers by having a dedicated counselor who could follow up those patients and a coordinator, and most of these patients had some kind of barriers, but almost the compliance right from 80%, it actually increased to about 92%, which in our context is a pretty good picture. Another intervention we've kind of, has done in the last year, which might be an option which we can consider at least to incorporate it in the government screening program, is screening for the white reflex. And this is something which can be very easily done even by the community health workers. And as part of our network, we have network of secondary centers apart from the tertiary care center at Delhi, and we have trained them to look for white reflex in a child's eye when they go for the pediatric eye screening for other things like squint and other things. And this device, the ArcLight, is something which is kind of very cheap sort of ophthalmoscope, which can be used even by a community level health worker to screen it. And this is again something not a great number, but out of the 7,000 children or so which has been screened till now, we could identify at least one child with a white reflex who turned out to be a bilateral retinoblastoma. And the important thing is the other sibling of the child, when we screened that one also as part of the screening, again had bilateral retinoblastoma. So at least out of those 7,000, 2 child could be picked up and sort of, saved. At least the eye could be saved, probably their life also. And this is something we can kind of, advocate for incorporating in the other pediatric eye screening programs of the country. So these are our experience and some of the things which, in addition to what you have mentioned, which probably we can sort of incorporate in our treatment along with our clinical treatment, and the management of RB goes well beyond the clinics. And a little bit more handholding is required.
Thank you so much, Seema. You can answer your screen. Ganga, do you have any comments on this?
No, thank you very much. I'm happy to share our perspective and very happy that you're organizing. You've probably been a messiah of changing ocular and ophthalmic oncology in this part of the world. I don't know how you managed to transform the minds of such young people. You trained such wonderful young leaders. I only hope I can clone you and bring you to this part of the world so you can probably do for the rest of Asia Pacific. I will have to take leave if you don't mind, for the other session.
Sorry for the delay. Dulika, can you just share Dr. Shantada's video? Dr. Shantada is traveling and he couldn't log in, so he has a video that we'll play and Dr. Reddy will discuss.
Sure, so just sharing the screen. Just a reminder to everybody who is joining for the quiz, please download the Kahoot app, or you can even log in on www.kahoot.in, and a gaming code will be generated once the quiz begins. And logging in that, you will be able to start the quiz.
Ideally, they should use 2 devices, otherwise it will be slightly confusing.
Yes, of course. I'll play the video, sir.
Rolika, the audio is not coming.
Rolika, share audio when you share this.
When you stop sharing and when you click on share, you'll get an option to share computer sound and optimize video.
Sure, sir. Just a second.
Yeah.
I'll try again.
Okay, dear friends, thank you very much for the invitation. I'd like to thank especially Santosh Honavar for inviting me for me to be with you today, discussing the topics of orbital and metastatic retinoblastoma, and if there's any hope in 2022. First of all, I would like to go over some considerations of regarding to staging, just because I assume that mostly the audience will be ophthalmologists. So even though there are some different staging systems in use, most of the groups in low and middle income countries use the International Retinoblastoma Staging System, which categorizes as stage 3 those cases that are orbital disease, also including the preauricular lymph nodes in this subgroup. And patients that are stage 4 are the ones that have metastatic disease and are subdivided between those that have CNS involvement, which are the stage 4B, and those who don't have CNS involvement, who are considered stage 4A. So the prognosis with current treatments is better for stage 3, little bit worse for stage 4A, but much worse, as you're going to see later, for stage 4B. This is not reflecting any biological difference, but mostly or any difference in the way the tumor disseminates, but only it has been graded according to the prognosis with the current treatments. But there are some considerations also in, are there any subgroups between these subgroups, between these substages beyond the IRSS? For example, as many groups in your country, in India, shown that patients with massive optic nerve invasion is a higher subgroups in stage 3. Patients with rather anterior orbital disease involving the orbital cavity, but not so widely the optic nerve, tend to have a better prognosis than those having massive
enlargement of the optic nerve as a tumor dissemination site. Also, it is critical to differentiate the patients that have prechiasmatic involvement. When the tumor invades through the optic nerve along the whole optic nerve, it will reach to the prechiasmatic area. These patients should be considered as stage 4B because this is an intracranial dissemination. Sometimes one might get confused because we'll think stage 4 is systemic dissemination, and this is kind of a higher grade of local regional dissemination. But we agreed to call this patient stage 4B because, as I said, this invasion is intracranial and should be considered as stage 4B. But some groups report patients that have been cured from prechiasmatic involvement. So some groups postulate that this patient could have a better prognosis compared to those with leptomeningeal disease, for example, in the CNS. Also, now that biological, I will go over in detail in the rest of the talk, patients with MECAN amplifications perhaps are a different subtype. They may behave differently. We're going to go over that in this talk. And also, more recently, based on clinical experience as well, I think you will all agree that some patients with bilateral disease don't behave as aggressively as most of those with unilateral disease. They tend to go slowly. We can even try eye salvage, and sometimes they even get metastatic disease, metastatic relapse many years after the diagnosis. So are they different? They should be considered different, should be treated differently. So these are also open questions in the issue of the treatment of metastatic retinoblastoma. And do these different subgroups matter in the relapse cases? This is very important because when we talk about staging for the pediatric oncologist, this means a diagnosis. So when we say this patient has stage 4A, is a diagnosis. When the patient relapses, this is the staging systems do not apply. But do these subgroups also apply for these relapse cases? We don't know. Let's going to try to find it out during my talk. So I briefly talk about molecular features of metastatic retinoblastoma. And fortunately, there have been a few publications in the past 2 or 3 years. And I think this one is published in Nature Communications last year. I think it's the most relevant one in the past few years, which reported, as we see in other pediatric tumors, that there are different subtypes based molecularly, that this also applies in retinoblastoma. We read in books that retinoblastoma have very little else than RB1 mutation and very few other mutation or chromosomal alterations. Well, this is not completely true when you study many patients and when you include patients with extraocular disease in your series. So based on this study, which was led by the Institute Curie team, where our group had the possibility of participating, we were able to describe 2 subtypes. The subtype 1 is the one that you would imagine from the literature, which would have very little else than RB1 mutation, good behavior, less they are less prone to give rise of metastatic disease. But there is another subtype, the subtype 2, which is described like also having, of course, RB1 mutation, but having the addition of other chromosomal alterations and other mutations like VCOR mutation. Typically, 1q gain, 16q loss, MECAN amplification. All the patients that had MECAN amplifications are subtype 2. And other that we are going to describe in short time. And why this is so important? Because all the patients that had metastatic disease in that study and in other one that we published also in association with many groups, including New York, Paris, Argentina, and Barcelona, all the patients that had metastatic retinoblastoma, either as diagnosis or at relapse, they belong to subtype 2. Only a couple of exceptions of patients with subtype 1 that were those that whose families declined enucleation. So finally, the tumor invaded the orbit, gave rise to CNS dissemination, mostly because contiguous extension through the orbit, which I know you are going to be more familiar than me in these cases because treatment compliance is more complicated in your setting. So patients with subtype 1 can be metastatic, but subtype 2 comprises the overwhelming majority of patients with metastatic disease, either at diagnosis or at relapse. And we could find a very good marker in transcriptomic analysis, which is TFF1. So these patients express TFF1, EBF3 is another one. And this is also very important because we were able, this paper is still in press, we were able to develop a immunohistochemistry technique for detecting expression of TFF1. So you see here in this chart that as the patient have metastatic disease, they tend to have higher expression of TFF1. TFF1 is not expressed at all in subtype 1. So 2 points, when you have patients with negative expressions of TFF1, very little possibility of giving rise to metastasis. And if the patient has TFF1 expression, those that have a higher expression have a higher likelihood, significantly higher likelihood of giving rise to metastatic disease. And in this subgroup, as I said, MECAN amplification is always subtype 2. And also, interestingly, we found, mostly in another study that I will show in a minute, we found that age can also be an important factor in the risk of giving rise to metastasis. So this is the paper I was mentioning. This is another paper our group published last year where we show in cases that had extraocular disease, you see here that the chromosomal pattern is somehow different. You see here a very well-known chromosome for pediatric oncology, which is 11q, which is commonly seen in neuroblastoma, is very common in patients that metastatic relapse outside the CNS mostly. So in that paper, we compared to others, and we showed that 100% of our cases had other chromosomal alterations. All of them were subtype 2. And also, interestingly, as you see, there were a couple of chromosomal gains, like or losses, gain of 17q, loss of 19q, that, as I said, 11q, as I mentioned, and that were almost exclusively found in patients with orbital or metastatic retinoblastoma. And interestingly, as you see in the graph, BCOR mutation was reported in 73% of our cases, which are or neither reported in other series, or maybe between 7, 10 to 14% in cases with non-metastatic retinoblastoma. And as I said, MECAN amplification is always subtype 2. With a few cases we had the chance to study. This is another publication together with a group in India, where we published 2 cases of metastatic retinoblastoma with RB1 not mutated, so RB1 wild type and MECAN amplification. And we see that these tumors tend not to include the CNS, tend to be refractory to neoadjuvant chemotherapy. And so that's why it's so important to have a radical excision of these cases, go to enucleation early in these cases and not waste more time. A few words about the outcome of these patients with recent therapy. These are the results yet unpublished by the COG. Hopefully this year they're going to be published. This is by courtesy of Ida Dunkel. You see that around 80% of the patients with stage 4A can achieve cure with intensive chemotherapy, including transplant. But on the other hand, children with stage 4B are really very, very poor prognosis and less than 10% survival. So this is the situation now, very good survival for stage 4A, but very poor survival with stage 4B, and most of the centers don't have transplant. So some groups cannot achieve this 80% survival. So we have to find new ways. You have to find how the tumor disseminates, and we have to be mindful that it is not useful to intensify further. It's not possible to intensify further systemic chemotherapy. We have to target chemotherapy in these two critical targets that we are not reaching adequately. One is the optic nerve. You see here that intra-arterial chemotherapy gets much better in the optic nerve compared to intravenous chemotherapy in an animal study, and also the CSF. There have been publications from the Canadian group a few years ago saying that topotecan is safe and effective when given intraventricularly or intrathecally. So in Latin America, there have been a few patients treated with this combined approach of intra-arterial carboplatin at systemic doses, very high dose of carboplatin intra-arterially, plus intravenous and intrathecal chemotherapy. And the few cases that were treated had a dramatic response against targeting the compartments where you can reach with systemic chemotherapy. This is a promising alternative. There are other ones like anti-GD2 immunotherapy that we are trying in also in a couple of cases in Barcelona, and where I try to answer the question if there's any hope, and I think there is, and hopefully these new combinations, these new ways of understanding how retinoblastoma disseminates and how could we better improve the drug delivery in the critical compartments may be helpful in the future. So thank you very much for your attention, and I wish you a very good meeting. Thank you very much.
But Vijay, can you come on the camera and please discuss? Dr. Vijayanand Reddy is the oncologist and possibly has the maximum experience in treating retinoblastomas in India, because he advises two centers, LV Prasad Eye Institute and Center of Sight.
Thank you, Santosh. Yeah, thank you, Santosh. And that's the reason is you. It's because of you I'm into this ocular oncology, and all the credit goes to you. Anyway, I wish we could have Dr. Chatinda on giving us the answers. I had pretty good questions to ask him. Unfortunately, he's not there. And anybody in the audience, if you can share their experience and how, very interesting to see that triple drug chemotherapy, what we do intrathecal for CSF metastasis, CSF positive disease. Unfortunately, the children are relapsing. As world over, the results have been quite poor in a metastatic setting, and more so in CNS involvement and CSF positive cases. I came across some of the papers where they started using intrathecal topotecan. So I think we should start in our place as well, in at least in salvage cases to start with, patients who come back after giving triple drug chemotherapy with CSF positive. So such patients, I think we should start using intrathecal topotecan. So other than that, we still are facing problems in a resistant retinoblastoma. And what is the second line chemotherapy that I would like to ask if somebody can throw some light on these patients? Unfortunately, we don't have effective drugs apart from VEC in resistant cases. So in such cases, we are trying to use anthracyclines and cyclophosphamide, but not much of a result that we are seeing. It's very, very interesting to know that chromosome analysis would let us know where we should stop and tell the patients that enough is enough and nothing is expected to work and go ahead with enucleation. So that's very interesting in his talk that we are able to look at some chromosomal abnormalities where we can advise the patient that further treatment is not going to be of major benefit or to save the globe. So good, and it's a massive 4.5 hours. I logged in at 5:30. I got to know so many things, new things happening across the globe. Thank you very much for making me part of this, Dr. Santosh. Anybody could answer at least these two questions. What are the second line or a salvage chemotherapy? Anybody across the participants or the international faculty if they can answer, if they have any experience in using second-line chemotherapy. I think most of them have already left, Dr. Santosh. It's too late. Somebody, Indian faculty, if they have any experience, they can answer. Otherwise, we let it go.
There is no oncologist in the audience except you.
Okay. All right. So then that's fine. That's about it.
Thank you, Vijay. Thank you so much. I thank all the faculty. We'll move on to the quiz next. Quiz is for the audience, and if any of the faculty want to participate, they're most welcome. It's a very basic quiz, and the theme is on the history of retinoblastoma. This is on Kahoot, as we already pointed out, and let me share. You can use a Kahoot app on your mobile, or you can use a website, kahoot.it website, to log in. The game pin will be seen on the screen, and you have to log in with a game pin. That is a game pin 446319. We'll wait for the players to join in before we start the quiz. Join in. Wait for 2 more minutes for folks to join in, and we'll start. I'm going to start the quiz now. The theme, as I said, is on the history of retinoblastoma. It will be played on Kahoot, as we already know. There will be 20 questions. Each question will have 4 possible answers for you to choose from. And the time to answer each question is 20 seconds after the question is asked. Once the time lapses, the last selected answer will be considered final. And if none of the options are selected within the limit, auto pass will be logged and Quizmaster's decision is final. And the scoring is based on fastest fingers. If you answer the question faster than your competitor, then you will get a higher score than if you don't. So let's go through the quiz next. First question coming up. Whose famous words are these? On 7th of April 1957, I opened the cranium of a 3-year-old book. Whose famous words are these? Correct answer is Petrus Clavius, and half of you have got that right. That is the leaderboard at this point in time. We'll go to the second question. By who and when was the current term retinoblastoma recognized? American Academy of Ophthalmology, American Ophthalmological Society, European Ophthalmological Society. Correct answer is American Ophthalmological Society in 1922. Going on to question number 3. The term fungus hematodis was first used by William Hay is the correct answer. Wardrop popularized it, but Hay was the person who got that term first. So three of you have answered it right. We'll go to the next question. First publication of a case of retinoblastoma in American literature occurred in which year, which journal? Correct answer is Medical and Surgical Register, which was a case reports journal, and it appeared in 1818. ICE is leading at this point in time, followed by MS. Those are the code words that they've used for themselves, and Vijita third. Who advocated early enucleation as a life-saving procedure for retinoblastoma? Wardrop. Half of you have got that right. Next question. Who demonstrated the technique of long optic nerve stump during enucleation? Who demonstrated? Many other things that he did, von Graffe also demonstrated the use of a particular surgical technique to get the longest possible optic nerve stump. He gets the credit for it. Next question. Who introduced radiotherapy for retinoblastoma in 1903? Hillgartner. Only one of you have got that right. Most of you thought it was Rees, but Rees, yes, he did popularize the protocols for radiation, but just 3 years after X-rays were introduced by Röntgen, Hillgartner was the one who used radiation for retinoblastoma. Who introduced radon seeds for retinoblastoma? The answer is Moore. Next question. Brachytherapy for retinoblastoma was introduced. Hillard is the correct answer. And he lost his leg for that. Next question. Who introduced cryotherapy for retinoblastoma? This is Linkoff. Systemic chemotherapy for retinoblastoma was proposed by which of these? The answer is Kalkaffer. Next question. Which issue of Archives of Ophthalmology, now called JAMA Ophthalmology, heralded the modern management? November 1996 was the one. It carried 4 articles by 4 different groups on intravenous chemotherapy called chemoreduction, which changed the management of retinoblastoma. Who described intravitreal chemotherapy for retinoblastoma? It was described first by Erickson, and nobody has got that right. What was the first drug used for intravitreal? Tipa is the correct answer. Who introduced melphalan for intravitreal? Which is the correct answer? Which pathologist noted endophytic and exophytic? Pittsburgh is the correct answer. Next question. Who drew the diagram? Who drew this? Intestinal is the correct answer, and I think most of you have got that right. Three more questions left. In which institution was Knudsen in when he described to I believe it was in MD Anderson, and that's the correct answer. Next question. Who coined the term retinocytoma? Well, Gally reported what she called retinoma clinically, but the very next year, Margot was the one who described the histopathological characteristics and coined the term retinocytoma. So Margot is the correct answer. Probably the last question coming up. Which edition of AGCC TNM classification? Most of you have got that right. That's AJCC 8. So let's go to this course next. Third prize, Deepika. We'll know the prize. Second prize, MS. Prize, I. Fourth is DPA. Fifth is Untitled. Please send me your number and email, my email or my mobile. Please know it already. You can contact me or to reach me, and AIOs will organize the prize. Thank you so much. Thank you for hanging on till the last moment, Dr. Munia. Thank you so much, Mahesh, Seema, Usha, Feroz, Rolika, and Raksha. Thank you.
Thank you, sir.
Thank you.
It
Thank
was
you
an
so much.
amazing learning.
Have a
And
nice
happy
weekend.
to meet everyone. Yeah. Thank you.
Thank you, everyone. Good night.
Good night, sir. Good night, everybody.
Good night.
Good night. Good night, Francis.